international presenters, dev item developer about the radiographer and competency test, evaluator of the Silem Kerma of higher education institution, journal reviewer, and resource person for community activities. The Radiodiagnostic and Radiotherapy Technique Department is equipped with facilities capable of supporting its academic activities. Amongst other are lecturer facilities, laboratory facilities, office facilities, library facilities, clinic facilities, guidance and counseling facilities, HIMA DEMA room, green open space, workshop facilities, parking facility, dormitory facilities, canteen, sports facilities, and also training institution secretariat facilities. Activities in the department consist of lecturers use the Healthy e-learning system, expert lecture, joint conference, radiology webinar. The academic atmosphere of the department is carried out by creating a conducive situation, interactive and innovative learning, developing scientific autonomy, and freedom of academic expression. Student services at department use the third SMART service system, which is available on the department website. Community service activities by lecturers of the Radiodiagnostic and Radiotherapy Technique Department include guiding student creativity activities as well as training and health promotion. Come join the Radiodiagnostic and Radiotherapy Technique Department. Regards, I help you. Integrity, hospitality, excellent, loyalty, professional, universal.
Attention please. Before we start today's activities, let us inform the first IConTRAS 2023 rules first. A. Participants are not allowed to disseminate Zoom meeting links. B. For radiographer participants, it is mandatory to use the Zoom account name that matches the registered name and participants code obtained from the committee, such as XXX, your name, example, 001 underscore Roni Gunawan. C. For students of the Health Polytechnic of the Ministry of Health Semarang, it is mandatory to use the last 6 digits of the name underscore real name. Example, 123002 underscore Aldila Fitriani. B. For participants from institutions outside the Health Polytechnic of the Ministry of Health Semarang, it is mandatory to use the institution name underscore real name. Example, Uniza underscore Dava Ilyasa. The committee will not admit ideas outside the committee's provisions. A. Participants can join and enter the Zoom meetings at 7:30 AM Jakarta time. F. Participants must dress neatly and appropriately when attending the webinar. G. Participants must mute their audio when joining the Zoom meeting. H. Participants activate video on during the event. I. Questions or statements related to the webinar material are submitted in writing via the provided link. G. a pretest will be given during the webinar. Okay. After the discussions and Q&A sessions, participants must take a post-test as a requirement to obtain the certificate. L. The requirement to obtain a certificate is to take both the pretest and post-test with a minimum score of 70. M. For radiographer, a certificate will be sent via Siapari or ID accounts less than 2 weeks. For participants other than radiographer, a certificates will be sent via the registered email. And a certificates will only be given to participants who attend the entire webinar, fill out the attendance list, and pass the committee evaluations according to point 10 above.
Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, please welcome to the first
IConTRAS, International Conference on Technology of Radiology and Applied Science. Excellency, President of Indonesian Society of Radiographers, Dr. Sugianto, Sarjana Pendidikan, Master of Applied Science, MRI. The Honorable Mr. Jeffrey Ardianto, Master of Applied Science, Director of Semarang Health Polytechnic of Ministry of Health. The speakers, Professor Kanaga Kumari Celia from Asia Metropolitan University, Malaysia. Puan Azizah Abdul Ghani, Bachelor of Science from Sultan Zainal Abidin University, Malaysia. Mrs. Dartini, Sarjana Kesehatan Masyarakat from Semarang Health Polytechnic of Ministry of Health. Vice Directors of Semarang Health Polytechnic of Ministry of Health.
The head of Radiodiagnostic and Radiotherapy Technique Department, Semarang Health Polytechnic of Ministry of Health. Dr. Fatimah, Sarjana Sains Terapan Magister Kesehatan. Secretary of the Radiodiagnostic and Radiotherapy Technique Department, Semarang Health Polytechnic of Ministry of Health, Mr. Nanang Sulaksono, Sarjana Sains Terapan Magister Kesehatan. The head of the Diplomatry Program in Radiology, Semarang Health Polytechnic of Ministry of Health, Mrs. Darmini, Sarjana Sains Magister Kesehatan. The head of the Applied Undergraduate Program in Radiology Imaging Technology, Semarang Health Polytechnic of Ministry of Health, Mrs. Dwi Rohmayanti, Sarjana Sains Terapan Master of Engineering. Lecturers and staff of Radiodiagnostic and Radiotherapy Technique Department, Association of Alumni, founders of Radiodiagnostic and Radiotherapy Technique Department, Chairman of APRI, Chairman of Pari Pengda Jawa Tengah, Chairman of Pari Pengcap Semarang, clinical instructors, and all of the invited guests.
Let us give thanks for the presence of Allah Subhanahu wa Ta'ala, who has given us grace in the form of health, safety, and gifts, so that we can join in the first IConTRAS 2023 with the theme Patient Safety. For your information, the International Radiology Webinar is a program organized by Radiodiagnostic and Radiotherapy Department of the Semarang Health Polytechnic of the Ministry of Health in collaboration with PP Pari. This activity is a form of our appreciation in conjunction to the International Radiography World Day 2023.
This event consists of webinar and e-poster and photography competitions, which had been held from 2 until 12 November 2023. The winner will be announced at the end of the event. The main aim of this event to open a space for discussions and collaborations between the three institutions regarding radiology issues related to patient safety. This event is supported by Konica Minolta and Fujifilm.
Allow me, Muhammad Hafid Giovanni and my colleague,
Michelle Ajung Francita,
as the master of ceremony to guide this event, let us convey the agenda today. The first is opening. The second is singing national anthem, Indonesia Raya, March of Pari, and March of Poltekkes Kemenkes Semarang. Sounding of the vision and mission of the Radiodiagnostic and Radiotherapy Technical Department. Praying, program report, speech, hand over the building fund, photo session, update technology by sponsorship, the speaker session, post test, and evaluation of the event, the announce of photography and e-poster competitions, and last, closing. Okay, first, singing the national anthem, Indonesia Raya, Mars Party, and Mars Poltekkes Kemenkes Semarang. Attendees are asked to place their right hand on their left chest during the playing of the national anthem.
Radiografer Indonesia bersatu padu di dalam cipta, tingkatkan kualitas sumber daya manusia, kuasai ilmu
welcoming speech. The first speech will be delivered by the Director of the Semarang Health Polytechnic of Ministry of Health, Mr. Jeffrey Ardianto, Master of Applied Science. Time is yours.
Thank you very much, MC. Let's check my sound. Is it okay?
Okay.
Okay.
Okay, thank you very much. I will start my speech, welcoming speech as Director of Poltekkes Kemenkes Semarang in the opening of the first IConTRAS 15th of November 2023. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning and best wishes to all of us. Salam sehat, sehat Indonesia, bersyukur. The Honorable, the Head of Health, Human Resource Planning, and President of PARI, Dr. Sugianto, Master of Applied Science, the Honorable Vice Directors and Management Board of Polytechnic Kesehatan Kemenkes Semarang, all of speakers, Madam Asisah Gani, BSc Horns from Hospital, Unisa, Prof. Kanaka Kumari Selila from Asia Metropolitan University, Mrs. Dartini, SKM MKes, Lecturer of Radio Diagnostic and Radiotherapy Techniques Department, PT Konica Minolta, PT Fuji Film, the head of departments in Poltekkes Kemenkes Semarang, the head of study programs and secretary, and all of department members, and the last, all distinguished guests and all webinar participants. On behalf of the organizer of the first IConTRAS, I would like to express my warm welcome to you all to the International Radiology webinar entitled Patient Safety in Radiology, Updates and Current Issues. This event is a collaboration of Department of Radiology, Health Polytechnic of Semarang, with Perhimpunan Radiographer Indonesia. The development of the health sector is one of the nation's priorities. To carry out complete health services, qualified and professional health human resources are needed in their fields. The development of the health sector is supported by high quality and health services. Patient safety is a long-lasting issue that needs to be improved in order to provide the best healthcare service. Radiology department has important role in the diagnosis support, but in another hand, there is harmful radiation that need to be concerned. Radiographers, as health workers who perform radiodiagnostic and imaging activities in healthcare units are required, must be able to ensure that the examination protocol and procedure are safe for the patient and the surrounding environment. Radiographers with high educational and professional standards also contribute significantly to strengthening radiation safety and the general safety of patient care in health services. Hopefully, this webinar can give contribution in the improvement of health services through promotion of quality patient care. Ladies and gentlemen, this event is the first international conference in Department of Radiology, Health Polytechnic of Semarang. But the webinar itself actually is the third annual event that is the part of the 128th World Radiography Day in collaboration with PARI. So its scientific benefits can also be achieved by fellow radiographers in Indonesia. We would like to thank the speakers who have been willing to share their time and knowledge. We hope that this good cooperation will continue. As the host of the event, we realize that the success of the webinar depends on Allah Subhanahu wa Ta'ala and several parties who have worked hard in planning and organizing this webinar. Therefore, I would like to thank the President of PARI, UNISA, and PT Fujifilm Indonesia for providing us with constructive support and advice, as well as the committee who have worked hard on the details and important aspects of the webinar. Last but not least, our gratitude also goes to the participants of this webinar. I wish everyone enjoys the seminar and the online model and success in every steps of our lives. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
I
wabarakatuh.
can give back the time to MCs. Thank you very much.
Thank you for the amazing speech by the Director of Poltekkes Kemenkes Semarang.
Terima kasih Pak Dir. Thank you very much. Sukses selalu.
Okay, you welcome. Mrs.
Yeah.
Fatima,
Yeah.
warm regards for you and also your faculty members. Thank you.
Thank you. Thank you.
Yes, sir.
Traditional dance performance by the students of Semarang Health Polytechnic of Ministry of Health. Please enjoy the dance, Dugderan Dance.
Kami, perwakilan dari Kendit, akan menampilkan tari kreasi yang berjudul Dugderen. Selamat menyaksikan.
sounding the vision and mission of the Radio Diagnostic and Radiotherapy Technique Department by Farah Diva Amalia. To Farah, time is yours. Vision and mission of the Radio Diagnostic and Radiotherapy Technique Department. Vision: becoming a department that projects intermediate radiographer who have radiation safety license, mastery of CT scanning and IT, as well as radiographer who are expert in the field of advanced imaging. Supported by managerial skills, have noble character and will be internationally recognized by 2025. Mission: 1. Organizing intermediate radiography expert education with mastery of CT scan technology and radiation safety. Novel character and a quality assurance system and supported by information technology IT that is measured at the end of its academic year. 2. Organizing advanced quality radiography and imaging specialist education supported by a quality assurance system at the end of its academic year. 3. Carrying out research and publication in the field of radiography and advanced imaging every year. 4. Organizing community service activities in the health sector every semester. 5. Improving the quality of human resources in order to support the three dharma of higher education. Establishing cooperation with government, private, and community institutions, both national and international level.
Next is prayer. Prayer that will be conducted by Faisal Regiasa. To Faisal, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Marilah sejenak kita bersama-sama menundukkan kepala, bermunajat kepada Tuhan agar kegiatan kita hari ini diberkahi dan diberikan kelancaran. Bagi yang muslim, izinkan saya memimpin doa, dan bagi yang non-muslim, silakan berdoa sesuai dengan agama dan kepercayaan masing-masing. Bismillahirrahmanirrahim. Allahumma sholli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. Alhamdulillahirabbil alamin wassalatu wassalamu ala asrofil anbiya wal mursalin wa ala alihi washabbihi ajmain. Amma ba'd. Ya Allah ya Rahman, pada hari ini kami hendak menyelenggarakan acara IConTRAS dengan memohon ridho dan izin-Mu. Berkahilah semua langkah dan perbuatan kami, dan jadikanlah itu semua nilai ibadah dan nilai ilmu yang bermanfaat kepada kami. Ya Allah ya Wahid, Engkau yang maha mempersatukan, jadikanlah momentum ini sebagai bagian dari usaha kami untuk menjalin tali silaturahmi satu sama lain. Kami mohon perkuatanlah persatuan di antara kami. Janganlah Engkau biarkan ada perpecahan di antara kami. Ya Allah ya Ghafur, Engkau yang maha pengampun atas segala dosa, ampunilah dosa kami, dosa orang tua kami, dosa. Ya Allah ya Tuhan kami, kabulkanlah permohonan kami, karena hanya kepada Engkaulah kami memohon. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wassalamualaikum warahmatullahi wabarakatuh.
The program report by the head of Radio Diagnostic and Radiotherapy Technique Department, Semarang Health Polytechnic of Ministry of Health. We would like to invite Dr. Fatimah, Sarjana Sains Terapan Magister Kesehatan. Time is yours.
Terima kasih. Thank you very much, Kak Michelle. Ya, suara saya bisa didengar? Can you hear me?
Yes, I can hear your voice.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning and best wishes to all of us. The Honorable Head of Health Personal Planning, Direktur Perencanaan Tenaga Kesehatan, Direktorat Jenderal Tenaga Kesehatan, and President of Indonesian Society of Radiographers, PARI, Dr. Sugianto, Sarjana Pendidikan Master of Applied Science. The Honorable Director of Poltekkes Kemenkes Semarang, Mr. Jeffrey Ardianto, Master of Applied Science. The Vice Director of Poltekkes Kemenkes Semarang, Prof. Dr. Ahmad Subaidi, Alatif Direktur Hospital Pengajar University Sultan Zainal Abidin, Associate Professor Dr. Wan Rohani Wan Thalib, Dean Faculty of Health Science University Sultan Zainal Abidin, Head of Medical Imaging School, University Sultan Zainal Abidin, Malaysia, Dr. Sofyan, President of Indonesian Society of Radiographers, PARI and members, especially Mr. Kukuh, Mr. Ferry, and Ms. Federica. President of Association of Radiographers Timor-Leste, Mr. Alberto dos Santos, and members, terima kasih. The Chairman of PARI Pengda se-Indonesia, PARI Jawa Tengah, PARI Kota Semarang, and members. The Chairman of Indonesian Association of Radiographers Education, IPRI, and members. The speakers, Madam Aziza Ghani, BSc, Hons from Hospital, Pengajar Uniza. Profesor Kanaka Kumari Selila from Asia Metropolitan University. Mrs. Dartini SKM MKes, Lecturer of Radiodiagnostic and Radioterapi, Teknik Departemen Poltekkes Kemenkes Semarang. PT Konica Minolta, terima kasih Mas Arga. PT Fuji Film, terima kasih Mas Ahmad. The Head of Department in Polkesmar, terima kasih semuanya Bapak Ibu Kajur dan Kaprogram Pasca Sarjana. The Head of the Study Program, Secretary of the Study Program, Lecturer, and Clinical Instructor in Department of Radiodiagnostic and Radioterapi, ya. Bu Dartini, Bu Darmini, Bu Yanti, Pak Gatot Murtiwibowo, dan semua Bapak Ibu dosen, clinical instructor, terima kasih semuanya. All distinguished guests and all webinar participants, thank you very much. First of all, let's ask thanks to Allah Subhanahu wa Ta'ala, who gives us health and prosperity to join this event. I'm really happy to be here to welcome all the participants of the first international conference of technology on technology of radiology and applied sciences, IConTRAS. Ladies and gentlemen, Poltekkes Kemenkes Semarang is the largest and foremost health polytechnic in Indonesia. We educate students from Diploma 3 to Applied Master. Our development, known as Jurusan Teknik Radiodiagnostik and Radioterapi, consists of 3 study programs. 3 years Diploma of Radiology in Semarang, 3 years Diploma of Radiology in Purwokerto, and Bachelor of Imaging Radiology Technology. The Department Radiodiagnostik dan Radioterapi Teknik commits in improving the learning quality as well as expand the international network to support the institutional goals achievement. The first IConTRAS is held in conjunction with the 128th years of World Radiography Day. This event consists of an international radiology conference photography competition, and scientific poster competition. The topic of the first IConTRAS is patient safety in radiology, updates, and current issues, which is relevant to the theme of World Radiography Day 2023. Ladies and gentlemen, the poster on and photography competition had been held from 5 until 13 November 2023. In the end, the event today, the champions will be announced. The first IConTRAS is attended by hundreds of participants consisting of students, lecturers, clinical instructor, and other participants from Indonesia, Malaysia, and Timor-Leste. I really appreciate your kind participation, and hopefully it can improve the networking among the participants. This event is held in collaboration with Indonesian Society of Radiographers PARI. We also invite the faculty members of University Sultan Zainal Abidin Unesa, Malaysia, Asia Metropolitan University, Malaysia, and radiographers from Timor-Leste. So, in this good occasion, allow me to convey my greatest appreciation to the President of PARI, Director of Poltekkes Kemenkes Semarang for the support, and the delegation from Unesa, AMU, and Timor-Leste for the participation. Hopefully, this collaboration will continue and improve the achievement among the institutions. And also, thank you to the speakers from Unesa, AMU, and Poltekkes Kemenkes Semarang who will bring interesting and useful topic and views for us. Last but not least, I would like to say thank you to PT Konica Minolta, PT IDM, and PT Fujifilm as the sponsorship partners. We hope radiographer and radiology students in Indonesia, Malaysia, and Timor-Leste will become better and able to be at the forefront of not only radiation safety, but also patient safety. Thank you. Salam CTRR. I help you. Integrity, hospitality, excellent, loyalty, professional, universal. Thank you for your kind attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, MC Kak Michelle.
Thank you, Bu Fatima, for the amazing speech today. And the next speech is from the President of Indonesian Society of Radiographers, followed by the official opening of the first IConTRAS. Good morning, Dr. Sugianto.
Hello, good morning, everybody. Can you hear my voice?
Yes, we can hear your voice.
Okay. Ya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam.
warahmatullahi wabarakatuh.
Good morning and best wishes to all of us. Salam sehat untuk semuanya. The distinguished director, vice director of Polytechnic Kesehatan Kemenkes Semarang. Also the speakers, Madam Aziza Abdul Ghani, Bachelor of Science Honors from Hospital Pengajar Unesa. Professor Kanaka Kumari Selila from Asia Metropolitan University, AMU. Ms. Dardini SKM, MCAS, lecturer from Radio Diagnostic and Radiotherapy Techniques Department. The head of departments in Britannic Delta, Parang. Also the head of study program and secretary of the study program in Department of Radiodiagnostic and Radiotherapy. All of the committee members, all distinguished guests, and all webinar participants. On behalf of Indonesian Society of Radiographers, I would like to express my warm welcome to you all to the International Radiology webinar. And the title is the Patient Safety in Radiology. Express my gratitude to our speakers committee of their unwavering dedication and hard work in supporting together this event. I really appreciate for Poltekkes Semarang of technique, radiodiagnostic, and radiotherapy that always commit to improve the quality of education, international networking. It is in line with the spirit of sama, sejahtera, and dunia. To all participants who joining this event from Malaysia, from Timor Leste, this webinar will improve your knowledge, improve your professionalism, especially in patient safety. I encourage you to actively engage in the discussion so you can share your insight and forge the new connection. That way together we can contribute to the growth and development of radiology as a discipline, and more importantly, enhance patient outcomes through our collective knowledge and expertise. Thank you for your attention, and I wish you all a rewarding and enlightening experience throughout this radiology webinar. By saying Bismillahirrahmanirrahim, this webinar is officially open. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Alhamdulillah, terima kasih. Thank you very much, Mr. Sugianto.
Ya, Pak. Terima kasih di tengah laut.
Ya, semoga selamat sampai tujuan ya. Sampai di Masohi, Pak Ki. Sudah di Masohi?
Sebentar lagi.
Oh, sebentar lagi. Ya. Masih nyebrang ya.
Di tengah laut.
Ya. Semangat. Amin. Amin.
Semuanya.
Salam untuk teman-teman di Ambon. Ya, terima kasih.
Ladies and gentlemen, the next session is the handover the building fund to the Pari Pusat. We would like to invite Dr. Fatima, Sarjana Sains Terapan, Magister Kesehatan, and Mr. Dr. Sugianto, Sarjana Pendidikan, Master of Applied Science.
Mohon izin Pak Ki, kami menyerahkan pemeliharaan gedung Gerapari untuk Pari Pusat ya, semoga berkah bermanfaat dari kegiatan webinar internasional di CTRR 2023. Semoga berkah bermanfaat.
Oke, terima kasih. Kami atas nama Pak Pusat ya, terima kasih ya atas kontribusi untuk pemeliharaan gedung Pari. Silakan ya teman-teman Poltekkes Semarang, di Jakarta, nginep di gedung Pari. Kita sangat terbuka welcome. Silakan ya. Adik-adik mahasiswa juga silakan untuk bisa tengok ya gedung Pari. Terima kasih.
Ya, sama-sama Pak Ki, sukses selalu.
Ya, jauh-jauh nih.
Ya.
Next is the handover the building fund to the Pari Pengda Jateng. We would like to invite Dr. Fatima, Sarjana Sains Terapan, to Mr. Dwi Adi.
Terima kasih Mas Adi. Halo, apa kabar? Sehat-sehat semuanya.
Alhamdulillah.
Alhamdulillah. Mohon izin kami, Mas Adi, dari CTRR akan memberikan penyerahan rintisan pembangunan gedung Sekretariat Pari Pengda Jawa Tengah kepada Pari Pengda Jateng. Semoga berkah bermanfaat dan mohon izin bisa diterima.
Terima kasih Ibu Fatimah atas kontribusinya. Atas nama Pengda Pari kami mengucapkan banyak terima kasih dan mohon doanya semoga gedung Pari Pengda Jawa Tengah ini segera bisa terrealisasi dan bisa kita gunakan bersama. Terima kasih banyak Ibu Fatimah.
Amin, amin, amin. Insya Allah ya luar biasa. Terima kasih.
Next is the handover the sponsorship certificate. We would like to invite Dr. Fatima, Sarjana Sains Terapan Magister Kesehatan, and the representative of Konica Minolta and Fujifilm.
Ya. Ya. Oke. Terima kasih. Di sini mungkin ada Mas Arga dari PT Konica Minolta, PT Internusa 2 Medica. Ya, kami aturkan apresiasi yang luar biasa. Thank you for your support dari PT Konica Minolta sehingga kegiatan ini berjalan dengan baik. Ya, terima kasih Mas Arga.
Sama-sama Bu Fatimah.
Yeah. Baik, terima kasih untuk tim PT Fujifilm atas support yang luar biasa. Kami haturkan sertifikat untuk penghargaan PT Fujifilm atas sponsorship yang telah disupportkan kepada kegiatan webinar internasional di CTRR. Ya, semoga berkah bermanfaat. Ya.
The next agenda is a photo session. To all of the participants, please open the camera. First slide. Second slide. Third slide. The photo session has finished.
Distinguished guests, ladies and gentlemen, the next agenda is technology update from Konica Minolta.
The distinguished participants, now we are in the main event.
My name's Florence Dew. I'm currently a resident physician at Mount Sinai West, and I do some research on dynamic digital radiography. Part of the excitement about this technology is that there's a lot of potential application and a lot of potential for the future. And part of it is because we can see things in the thorax that we couldn't see before, also in the muscles, and also for therapeutic monitoring. A lot of the projects we're working on are really different than what's been possible before, mainly because before you could only see the anatomy. You could only diagnose things that were on static images, and now you can get a lot of the functional information that just wasn't described in an imaging format. Because before, with pulmonary function testing, you could only get a global picture of the lung in a numerical format with a graph, kind of diagnose and treat things like COPD. But with dynamic digital radiography, you could possibly put that into one single line exam. So that means that you can see the lung disease in a geographic format. You could kind of pre-diagnose things such as COPD and kind of tailor the treatments that way. And that's just one application. It can be very exciting. I would say that that's a different kind of thought process that would go into the differences between CT or MR. I would say digital radiography is actually different from traditional radiography more so than it would be different from CT/MR, because CT/MR is a different second line examination that gives you a different kind of resolution of the lungs. You would get multi-sectional analysis for lung nodules, for example, or high resolution areas to examine fibrotic lung disease. You may not get that immediately because your insurance company might not cover it. It might be due to because that's not the best modality per se to access that information, but you do want to get a radiograph as a first line examination to get a picture of what you're looking at. And you would get that in the ED, you would get that as an outpatient, you would get that in a hospital setting, and that's basically what every hospital does. It's 40% of all examinations in the world. X-ray is very different in that format because CT and MR is just not accessible for a lot of places in the world, and it just doesn't give you the same picture that dynamic digital radiography or traditional radiography would do. And you would definitely order those as a more advanced examination. The research is multifaceted. Because dynamic digital radiography has multiple applications, there's different avenues of research we're pursuing. One is because it's so novel, radiologists have not yet been able to develop a new report for it because we don't know exactly what we're seeing. It's very exciting in that it's almost like developing, the first ever radiograph where when you first had to diagnose something, you would say, I think there's pneumonia, and then correlate that with your other clinical colleagues, and then come back and say, yes, that's a pneumonia, or oh no, that's a lung cancer that's also there. And you would start developing a differential diagnosis. So in that same way, we are looking at the lungs and the way that they're presented in a dynamic format, and we want to see if there's new types of ways of describing those findings. So for example, diaphragmatic motion, with one side being more paralyzed than the other. We want to see if it's possible to accurately diagnose things like COPD, restrictive lung disease, and other types of thoracic diseases that may not have an imaging correlate yet on at least a single first-line examination.
From Konica Minolta, please welcome Mr. Arga to give a little speak.
Okay. Good morning, everyone.
Good morning, Mr.
So,
Arga.
thank you for this session. So in this part, my teammate will representative Konica Minolta. She is business manager from Internusa 2 Medica or PT IDM. So for Mrs. Faradita, time is yours.
Oke, terima kasih Mas Arga. Terima kasih Bapak Ibu MC atas kesempatan yang telah diberikan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
wabarakatuh.
Waalaikumsalam.
Selamat pagi semuanya. Yang saya hormati Bapak Jeffrey Ardianto, Bapak Sugianto, Organisasi Pari Pengda Jawa Tengah, dan Ibu Dr. Fatimah. Yang saya hormati Bapak dan Ibu sekalian yang tidak bisa Farah sebutkan satu persatu, tetapi tidak mengurangi rasa hormat Farah. Saya Farah Dita Tamba, selaku Business Development Manager Digital Imaging dari PT Internusa 2 Medica dan selaku Sole Distributor Konica Minolta. Pada kesempatan kali ini, Farah ingin mempresentasikan mengenai informasi Minolta. Next, Mas Arga. Oh ya. Sebelumnya, Farah ingin menginformasikan profil dari Konica Minolta. Konica Minolta berdiri sejak tahun 1873, jadi tepat di tahun 2023 ini 150 tahun. Mungkin Bapak Ibu sebelumnya mengenal Konica Minolta dari mesin fotokopinya, tapi untuk bidang kesehatannya sendiri sudah mulai dari tahun 1989 untuk alat prosesor kamar gelap, tahun 1993 untuk alat CR komputer radiografi, tahun 2003 untuk alat PACS, tahun 2011 untuk alat flat panel detector atau retrofit, tahun 2018 untuk software dynamic digital radiografi atau disingkat dengan kata DDR, dan tahun 2022 untuk mobile DR dynamic digital radiografinya. Slide, Mas. Next. Untuk populasinya sendiri, flat panel detector atau retrofit, data ini terupdate bulan Juni tahun 2023, yaitu sebanyak 48.500 unit, di mana Amerika ada 16.000 unit, Eropa ada 6.000 unit, Asia 7.500 unit, dan Jepangnya sendiri ada 19.000 unit. Next slide. Dari slide ini menginformasikan bahwa stationary X-ray digital merek GE pada dasarnya banding dengan flat panel detector atau retrofitnya dari merek Konica Minolta. Karena untuk GE-nya sendiri tidak memproduksi untuk flat panel detector atau retrofitnya. Dan terlampir untuk situs link yang menyatakan flat panel detector atau retrofit Konica Minolta provide integrated terhadap stationary X-ray digital GE. Next. Terlihat dari slide ini, benefit dengan menggunakan flat panel detector atau retrofit dapat mempersingkat alur workflow sehingga menjadi 5 kali lebih cepat proses hasil image-nya karena tidak perlu lagi membawa kaset ke ruang X-ray dan menghilangkan proses scanning kaset CR ke digitizer CR. Next. Selain dari sisi alur workflow yang menjadi lebih cepat, benefit lainnya yaitu flat panel detector atau retrofit juga dapat menghemat anggaran dari maintenance. Tidak perlu ada pergantian atau penambahan kaset CR dan perbaikan part dari komponen CR. Next. Terlampir untuk portofolio produk Konica Minolta yang dibawakan oleh PT Internusa 2 Medica, di antaranya ada printer, film, CR, dan beberapa tipe flat panel detector atau retrofit, di mana ada tipe yang masih menggunakan baterai, yaitu Aero DRNS, dan ada tipe terbarunya dari Konica Minolta yang sudah glass free design dan free baterai, yaitu kita menyebutnya dengan Aero DR3 family. Di mana Konica Minolta untuk flat panel detector atau retrofitnya dengan teknologi terbarunya yaitu sudah glass free design dan lithium ion baterai free. Next. Untuk material trend market sendiri, teknologi yang digunakan yaitu cesium, flat panel detector atau retrofit Konica Minolta dari yang tipe entry level sampai yang tipe Aero DR3 family, bahan materialnya sudah cesium, di mana dapat menyerap X-ray lebih baik dibanding yang material masih teknologi Gadox. Next. Konica Minolta answer dengan menjawab dengan perkembangan teknologi yang pesat. Konica Minolta mengupdate yaitu next. Karena flat panel detector atau retrofit Konica Minolta sudah glass free design seperti terlihat di slide, di mana TFT sudah tidak lagi dijepit oleh kaca, sehingga apabila tidak sengaja terjatuh dari batas ambang 1,2 meter tidak akan pecah dan tidak akan memunculkan artefak. Dan untuk berat flat panel detector atau retrofit Konica Minolta sendiri, karena sudah tidak ada unsur kaca, yaitu hanya 1,9 kilo saja untuk berat flat panel detector atau retrofitnya. Next. Untuk resolusi dari flat panel detector atau retrofit konika minolta yaitu sudah 100 mikron, dan untuk DQE atau tingkat sensitivitas terhadap sinar X-ray-nya sendiri sudah di angka 59%, sehingga dapat membuat hasil gambaran lebih tajam, menurunkan faktor exposure-nya, dan juga dapat meminimalkan paparan dosis radiasi secara signifikan. Next. Di bagian sisi bodi dari flat panel detector atau retrofit konika minolta sudah monocoque dan materialnya menggunakan karbon. Dari gambar yang sebelah kanannya yaitu di mana flat detector atau retrofit konika minolta dijatuhkan sebanyak 26 kali sisi, tetapi masih bisa beroperasional dengan baik dan sudah standar militer. Dan flat panel detector atau retrofit konika minolta sudah IPX5 yaitu anti debu, dan sudah IPX6 waterproof karena sudah tidak ada jendela atau celah yang bisa memasukkan air ke dalam flat panel detector atau retrofitnya. Next. Di mana dengan teknologi lithium ion baterai untuk tingkat keamanan tidak mendukung. Seperti hal yang tampil di slide dapat mengakibatkan percikan api atau baterainya bisa kembung atau soak atau pemutusan aliran listrik saat mencharger. Next. Di mana adanya perbedaan signifikan antara teknologi yang masih menggunakan baterai dibandingkan dengan teknologi terbaru, yaitu dengan menggunakan kapasitor. Pertama, dari tingkat keamanan, kapasitor jauh lebih aman dibandingkan baterai. Dan yang kedua, dari umur pemakaian, baterai hanya 300-500 kali charger, atau perkiraan 1-2 tahun, sedangkan menggunakan kapasitor 100 kali lebih lama, yaitu 40.000-50.000 kali charger. Sama dengan lifetime atau umur flat panel detector atau retrofitnya sendiri. Dan yang ketiga, untuk sistem chargernya sendiri, untuk baterai butuh waktu 3-4 jam dari 0 sampai 100%. Sedangkan untuk teknologi kapasitor jauh lebih cepat, yaitu cukup 13 menit dari 0% sampai 100% untuk tipe yang Aero DR3SL, atau bisa disebut dengan fast charging. Next. Konica Minolta ada beberapa unit software yang dimiliki, yaitu ada Realism, Bone Suppression, Intelligent Grid, Dynamic Digital Radiography atau DDR, dan Mini PACS. Next. Di mana dengan unit software Realism dari Konica Minolta, yaitu sangat membantu untuk cara operasionalnya cukup one click, dapat secara otomatis memberikan hasil image yang lebih realistis. Bapak Ibu bisa lihat perbedaannya di mana image yang sebelah kiri yaitu sebelum one click realism dan image yang sebelah kanannya setelah one click realism. Terlihat lebih jelas ya Bapak Ibu. Next. Dan di mana dengan unit software Bone Suppression dari Konica Minolta sama halnya dengan software realism, untuk cara operasionalnya cukup one click. Jadi dapat menghilangkan tulang iga atau koste sehingga dapat memudahkan diagnosa lebih cepat dan akurat apabila terdapat nodul yang tertutup oleh tulang iga atau koste. Untuk image sebelah kiri, di mana sebelum diklik bone suppression, dan untuk image yang sebelah kanan setelah one click bone suppression. Terlihat lebih jelas juga ya Bapak Ibu. Terlampir, next. Dan untuk unit software yang berikutnya yaitu Intelligent Grid atau yang disingkat dengan IG, tapi bukan Instagram ya Bapak Ibu. Terlampir Bapak Ibu di mana image yang sebelah kiri yaitu image di mana tanpa grid fisik tambahan, image yang tengah yaitu image di mana menggunakan grid fisik tambahan, dan image yang sebelah kanan yaitu image di mana tidak menggunakan grid fisik tapi menggunakan software Intelligent Grid yang sudah tertanam di dalam software Konica Minolta, sehingga dapat menghasilkan image yang sama bahkan lebih detail dan tajam dengan menggunakan grid fisik tambahan. Next. Untuk software yang selanjutnya yaitu Dynamic Digital Radiography atau DDR, di mana dapat memberikan image yang bergerak sehingga dapat menginformasikan lebih banyak informasi dari image tersebut. Next. Seperti yang terlihat Bapak Ibu, image yang sebelah kiri yaitu image yang pada umumnya atau saat ini yang Bapak Ibu fungsikan. Dan image yang sebelah kanan yaitu unit software DDR dari Konica Minolta, di mana image dapat bergerak sehingga yang didapat bukan hanya informasi anatomis saja, melainkan informasi anatomis dan ditambah informasi secara fisiologis. Next. Pasti Bapak Ibu bertanya gimana cara kerja untuk bisa image-nya bergerak. Untuk cara kerja dari DDR yang ada di Konica Minolta, yaitu menggunakan pulse X-ray, yang dimana nantinya dari pulse X-ray tersebut diolah oleh software DDR Konica Minolta menjadi image gerak dengan durasi 10-20 detik, di mana 1 detik itu bisa 15 frame. Untuk dosis radiasinya sendiri itu hanya 1,64 mg, bahkan lebih kecil dari image PA plus lateral, yaitu 1,9 mg. Next. Next. Kemudian dari gambar gerak tadi bisa diolah kembali menjadi berbagai mode yang memiliki fungsinya masing-masing, yaitu bone suppression mode, terus FM mode, DM mode, LM mode, PL mode, dan PH mode. Sehingga dari berbagai mode tersebut dapat membantu observasi apabila ada kelainan anatomi, dapat menginformasikan secara kuantitatif, dan juga memudahkan evaluasi secara fungsional. Next. Fungsi mode dari fitur DDR Konica Minolta diantaranya mode yang pertama yaitu bone suppression mode, di mana pada mode ini dapat menyamarkan gambar koste sehingga benefitnya bisa memperlihatkan luas area paru dengan lebih jelas. Dan untuk mode yang kedua yaitu LM mode, di mana pada mode ini dapat memperlihatkan gerakan pada soft tissue paru. Dan mode yang ketiga yaitu DM mode, di mana pada mode ini dapat memperlihatkan gerakan diafragma yang hasil dari DDR tersebut dapat berupa data numeric yang disinkronkan dengan fisiologis tubuh. Dan mode yang keempat yaitu PL mode, di mana mode ini dapat menampakkan distribusi udara di lapangan paru yang disinkronkan dengan fungsi fisiologisnya. Dan mode yang terakhir yaitu mode yang kelima yaitu PH mode, di mana pada mode ini dapat memperlihatkan blood flow di area paru tanpa menggunakan kontras. Next. Selain itu, DDR Konica Minolta juga melakukan pengembangan dalam suatu case ortopedi. Jadi tidak hanya berfokus pada pemeriksaan toraks saja. Software DDR bisa juga untuk menampakkan pergerakan sendi seperti mengukur jarak gerak sendi dan mengukur sudut gerak sendi. Seperti yang terlampir di slide. Next. Dan ini untuk DDR line up-nya, terlihat Bapak Ibu untuk paketan dari mobile DDR Konica Minolta. Untuk saat ini yang sudah ada software DDR-nya yaitu ada di alat mobile DR Konica Minolta. Di mana pastinya ada pesawat mobile X-ray-nya, DR plate, dan workstation DDR-nya. Untuk desain mobile DR-nya sendiri juga sangat ramping. Next. Konica Minolta juga ada produk untuk PACS-nya dan juga IT workstation-nya yang dimana ada software AI yang setelah foto langsung melingkari untuk menginformasikan adanya kelainan pada toraks. Setelah itu ada bone suppression yang menghilangkan koste, terus juga bisa mammo CAD, dan yang terakhir dose management di mana radiografer tidak perlu lagi mencatat dosis radiasi secara manual. Dengan dose management yang ada di IT workstation Konica Minolta, dapat secara otomatis untuk pembuatan laporan dosis yang biasa dimintakan oleh Bapeten. Next. Jadi pada IT Workstation Konica Minolta, apabila Bapak Ibu mau ada software AI, bone suppression, mammo CAD, dose management, bahkan bisa berfungsi sebagai mini PACS juga, itu bisa terkoneksi dari alat X-ray atau flat panel detector merek lain apapun. Jadi tidak hanya merek Konica Minolta saja, tapi merek lainnya bisa cukup dengan membeli IT workstation-nya saja ke kami. Mini PACS sendiri bisa terkoneksi 5 modality dan 10 klien. Next. Sekian Bapak Ibu informasi presentasi yang dapat Farah berikan. Lebih dan kurangnya Farah mohon maaf. Jika ada pertanyaan yang lebih lanjut tentang Konica Minolta, dapat menghubungi Farah langsung. Salam sehat dan sukses selalu untuk semuanya. Terima kasih. Farah izin tutup. Billahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Selamat pagi semuanya.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih.
Thank you to Konica Minolta for the amazing presentation.
the distinguished participants. Now, we are in the main event of the first IConTRAS International Conference on Technology of Radiology and Applied Sciences 2023. The speaker sessions will be guided by our moderator, Mr. Ahmad Haris Sulistiadi, Sarjana Sains Terapan Magister Kesehatan. Time is yours.
Thank you to the MCs. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning and best wishes to all of us. His Excellency, President of Indonesian Society of Radiographers, Dr. Sugianto, Sarjana Pendidikan, Master of Applied Science, the Honorable Director of Poltekkes Kemenkes Semarang, Vice Directors and Management Board of Poltekkes Kemenkes Semarang, the speakers, Head of Radiodiagnostic and Radiotherapy Technique Department, Secretary of Department, Head of Study Programs, Secretary of the Study Program, all distinguished guests from PARI, from UNISA, from Asia Metropolitan University, from Timor-Leste, and all webinar participants. Welcome to the first IConTRAS, entitled Patient Safety in Radiology, Current Issue and Updates. It is an honor for me to be the moderator for this insightful session. My name is Haris. Allow me to guide you in this session. Ladies and gentlemen, safety has no holiday. Patient safety is a long-lasting topic to be discussed. It has to be our concern because our main job as health workers is to provide health services, save people's life, or improve their health quality. Radiology has an important role in health services, and in other side, it has scary effects of radiation. Today, we have the privilege of hearing from two distinguished speakers, each bringing their expertise to the forefront of our discussion. Our first speaker is Puan Aziza Abdul Ghani, Bachelor of Science from University Sultan Zainal Abidin, Malaysia. And the second one is Mrs. Dartini, Sarjana Kesehatan Masyarakat, Magister Kesehatan from Poltekkes Kemenkes Semarang. Each speaker will have a dedicated 30 minutes for their presentation and allowing for a deep dive into the subject matter. There is a question and answer session after each presentation. For the first session, I would like to invite Puan Aziza Abdul Ghani. Good morning, Puan Aziza. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Can you hear me? Can you hear my voice?
Yes, your voice is very clear here.
All right, thank you.
Okay, ladies and gentlemen, allow me to convey a brief CV of Puan Aziza. She is a senior radiographer, or in Malaysia, it called by Juru X-ray at Hospital Pengajar University Sultan Zainal Abidin. She was born 52 years ago, graduated with Diploma Medical Radiography from School of Radiography, University Malaya in 1995. And she got Radiation Protection Officer certification in 2010. Finished her Bachelor of Science in Medical Imaging, University Technology Mara in 2012. And recently, she is going on her Master of Science in Faculty of Medicine at UNISA. She has 28 years experience in medical imaging field. Started as radiographer in 1995. She had about 12 years of clinical experience in a few medical centers. She has about 15 years of teaching experience. And she has a strong background in medical imaging techniques, instrumentation and radiation protection, as well as anatomy and pathology. And ladies and gentlemen, in this occasion, Wan Aziza will talk about patient safety, optimizing the patient's dose in digital imaging. And without further ado, please welcome Wan Aziza. The time is yours.
Thank you, Mr. Haris. Okay, firstly, Assalamualaikum and very good morning to everybody. Thank you for the kind introduction. The president of PARI, Dr. Fatima, all lecturers and students, all radiographers and all the webinars participants. Okay, let me share my screen. Okay, can everybody see my screen?
Yes, it is already.
Okay. Okay, firstly, thank you for the organizer and congratulations for organizing this first international conference on technology of radiology and sciences. Congratulations also to Polkes Kemenkes Semarang, and thank you for this opportunity for me to join this event today. Salam kenal from Malaysia, khususnya dari Universiti Sultan Zainal Abidin, Terengganu, Malaysia. Okay, my topic today is about patient safety, optimizing the patient's dose in digital imaging. So as we know now, the digital imaging is very upgrading. So we are going to I'm going to share about the optimizing of the patient's dose in the digital imaging. Firstly, it is still in the vibe of World Radiography Day. So let me wish everyone happy World Radiography Day 2023 with the theme of celebrating patient safety. So for today, what the issue that I'm going to share, firstly about the optimization, what is the optimization? Secondly, we will see about firm screen system versus digital system to understand more of the optimization issue. And then we will see what is the issue of the digital imaging. And next, lastly, we will see what is the practical guideline for the radiographers in the related issues. Okay. Okay, we all know that in radiation protection principles, we have three main principles. So one is the justification, second is the optimization, dose limitation. Okay, so for the justification, it's actually we need to make a decision. For any decision that alters the radiation exposure situation should do more good than harm, more benefit than the risk. Okay, in optimization, there is a likelihood of the incurring exposure, the number of people exposed, and the magnitude of their individual doses should all be kept as low as reasonably achievable. Our famous or our important of ALARA, and taking into consideration of also the socio-economical factor. And in those limitation, that is the total dose of any individual from regulated sources or in planned exposure situation other than medical exposure of patient should be not exceed the appropriate limits specified by the Commission. So we know that we have the workers dose limit, we have the public dose limit, we have the students dose limit, we have the pregnant workers dose limit. So it is all must be within the range or the dose limitation allowed. Okay. So what is the optimization? Optimization is does not actually simply mean to minimize the patient dose and maximize the image quality, because we know dose of the patient, we need to put it as low as possible, and by the time is we need to increase our image quality of the radiographs to the maximum as possible. But it does not simply means the maximize the dose and minimizing the image quality itself. Because the optimization is actually finding the balance between these two factors, we must ensure that image quality is sufficient for the accurate diagnosis for the radiologist to make the diagnosis, and at the same time, patient dose is kept as low as reasonably achievable. Okay, next, let me see the dynamic range. Okay, here there is showing here is the dynamic range of film screen system and the digital system. So as we know, in conventional screen system, we have one here, the green color is the optimum exposure that we need to give to any examination to get the full or the optimum response of the film to get the good image. Any exposure below or above this range will not give the optimum images or the good radiograph. As we can see in different situation in digital imaging system, we know that digital system has a wider dynamic range, where the optimum exposure in green portion here is wider, and we actually can play with the minimum and the higher exposure that will still give us a good and quality image. And as we can see also here, the saturation part of the exposure in digital imaging system is very small portion or less compared to our conventional film screen system, where as we know, it is very critical in conventional film system that we need to give the specific or correct exposure to get the good and quality image. Okay. So as we know, in conventional radiography, the excessive exposure will give us black film, inadequate exposure will give us white film, and these both will actually reduce our image contrast and will not get any information from the very black or very white film. Whereas in digital system, image brightness can be adjusted proportionally, independent of the exposure factor was given to the images. This is the advantage actually for the digital imaging or digital system, that we can play around with a wide range of exposure factor. Okay, in digital imaging, there are now many medical facilities are replacing film screen films radiography into the filmless radiography, including CR and DR. So unlike the film screen system, both CR and DR has a large dynamic range. So it is actually quite easy to unknowingly expose or overexpose the patient, because in digital imaging, we know that we can give a wide range of exposure and we can give higher exposure than normal, then we can still correct the image using the post-processing function. It is therefore important to check that patient doses do not increase during the transaction of the digital system. So as we know, the digital system has many advantages. So let's see what is advantages of the digital imaging. So digital imaging has better diagnostic information compared to film screen system with the comparable patient dose. It's not to say like a very low dose, it's actually as higher dose, but a comparable patient's dose. And with wide contrast dynamic range, it has also the post-processing functions. That means you can adjust the window and you can adjust the images, the contrast, according to your need. And it also has multiple image viewing function, and you can do the electronic transfer and archiving possibilities. So in digital imaging, how does it reduce dose? Actually, because just now I say digital imaging is actually not giving the low exposure, but it's about the higher exposure. So in digital imaging, the dose is reduced by somehow reduce the examination retake due to under or overexposure. And with the wide range, wide dynamic range is actually enable varies of the exposure factor without influencing the image contrast, thus lower the patient radiation dose and result in image quality that is adequate for the radiologist to see and make diagnosis, and reduce need to the additional views or in some cases. Because we know last time in last days in film screen system, we actually need to give a specific exposure to get a good image. And sometimes if the radiologist cannot see clearly, they may ask for additional views, and some may need additional projection also. Okay, so saying the advantage of the digital imaging, so what is the issue? What is the actual issue with the digital imaging? So now we have to put it here as before the digital era, the X-ray images were recorded on the film, and if radiographer used too much or too little exposure during the examination, it can have an immediate feedback. Okay, example, too much dose produce dark image, too little dose result in light image. Okay, but with the digital imaging receptor can compensate the different level of dose. So if the radiographer is not being careful, the radiation doses can increase. This is the reported by PISE in 2022. In digital radiography, it is possible to expose too much radiation without compromising the image quality. And due to lack of visual control, there is a risk of rapidly increasing the patient dose. And actually in ICRP in 93 editorial actually has warned us this digital technology that is advancing rapidly and will soon affect hundreds of millions of patients where it is now happening. And if the careful attention is not paid to the radiation protection issue in digital radiography, the medical exposure of patient will increase significantly and without concurrent benefit. So the dilemma of the radiographer is, if the dose is high, the image quality will be excellent. But if the dose is low, the image will be unacceptable to the radiologist and they will not happy with it. So in most cases, radiographer tends to give more exposure because they know that at the end, after that, the image can be corrected. So high doses may be overlooked. So for most of us, seeing is believing. So let's have a look to understand what this I mean. Okay, I will show some radiographs here. Okay, in this exposure is made in digital imaging. Can you see any difference among the images? If you can see here, there is 4 images here. It's about the same density and contrast and about the same exposure. But however, if you can see clearly here, there is some blurring or you say like noisy here compared to the first 3 radiograph. Okay, this radiograph is actually taken using the same KVP but different MAS. Okay, let's see here. This first radiograph is taken with 1 MAS. Okay, let's say I will use here 60 kVp with 1 MAS, and this radiograph is actually underexposed, but during the post-processing, this image is corrected digitally. The second image here is using 5 MAS, say 60 kVp and 5 MAS, which is the optimal radiation or optimal exposure. And the image is looking very good here and with high image quality. The third image here is using 25 MAS, 5 times over exposure to the patient. And this image is actually overexposed, but still post-processingly, they can produce same images, same good images that radiology can accept and can see and make the diagnosis. And the last images here is using 60 MAS with 50 MAS, which is 10 times over. And this is a gross overexposed to the patient unnecessarily. But in digital imaging, we can still do the post-processing to make it look like the perfect or optimum images. So as you can see here, the effects of digital imaging actually, we can actually another way, it is the advantage of digital imaging, where if you give lower exposure or higher exposure, it will come to post-processing, and we can actually give a good images, and we don't have to repeat if there is overexposure. Okay, but in another way, we actually giving extra radiation to the patient. Let's see now different between film screen versus digital imaging, digital images film. This is a study done by Cooper and team in 2011, doing the exposure on this animal using the conventional film and digital image. So the first image here is using 60 kVp and 1 MAS. In both conventional and digital image will produce good images. You can see it very well. The heart contour and the lungs here, you can see it is good and acceptable images. So let's next see the sorry. Okay, sorry. Sebentar ya, saya slide macam terhenti seketika. Sekejap. Minta maaf terhenti seketika. Saya perlu share semula ya, sekejap. Okay, Mr. Haris, can you see my slide now? You're muted actually. Okay, may I continue? Boleh? Okay. Okay, minta maaf saya ulangi ya. Di sini, okay. Okay, tadi di sini saya sambung ya. Okay, so we see here the images here with the optimum exposure parameter with 60 and 1 MAS. It produced the both images, both good images. So now, actually, okay, this is using 60 kVp and 0.1 MAS. In conventional images, it shows only white images here, so we cannot see any structure. But in digital images, we can still see the images, although it's a bit low quality, but you can still see the lungs and the lungs of the animal here. This is actually under exposure parameter. And next, this actually an overexposed parameter using 60 kVp and 4 MAS. In conventional images, conventional film, we can only see actually a black film or a burnt film or overexposed film. But however, in digital images, we can still see the images with actually a good resolution, because this we are using the high exposure, high MAS. So in digital image here, it is actually overexposed film, but it is get corrected in the digital system. For this conventional image, if we use the higher exposure or overexposed exposure, we actually can see some detail, but it actually superimposed of too many photons here. That's why it gets black here. And I remember my lecturer once said, if you produce a black film or overexposed film, it's actually it is actually not overexposed film, but it is a film that have too much information in it, superimposed. Okay, that's it. This is a joke or a trick lah to like mention to anybody. If we actually produce black images, it is actually not a burn film, but it's actually there are too many information inside here, but it is actually superimposed with the too much of the radiation. Okay. Sekali lagi mohon maaf, dia berlaku lagi sekali. Saya terpaksa.
It's okay, Puan. To the participants, we would like to inform you that the link of a question is available in the chat menu. There are 10 minutes remain.
Okay, I continue, yeah. Okay, so with these images of the overexposed parameter, it is actually you can get a good image with 60 and 1 MAS as well as 60 and 4 MAS in digital system. So if you can use lower exposure, why do we use the higher exposure? Because the lower exposure is actually enough or adequate to produce the images. So if we can, this researcher keep increasing the MAS and try to do it processingly to check how much the maximum radiation or maximum MAS can be used in this study, and it is come to at the end of 60 kVp and 128 MAS. It is over 1,000 times than the optimal exposure, and the digital imaging system can still correct the images to give a good and optimum or diagnostic images. Can see here in this study, actually the digital imaging is very good, very advantage system, but in other way, if we are not careful, it can give extra radiation to the patient. But in this case, it is over 100 times higher, and you can still produce the good image. So this situation is called dose creep. Okay, what is dose creep? Dose creep is the loss of visual cue in digital imaging. Okay, what is visual cue means? Visual cue means when in conventional film, conventional imaging, radiographer will know if he or she give less radiation or underexposed or overexposed. But in this digital imaging, the radiographer do not realize if he or she give extra radiation to the patient, because any radiograph that come out in the system, we actually can correct the images. And high dose rewards to the good image quality. Of course, we know that high kV and high MAS will give us a good image quality. And radiographer tends to give a higher exposure factor to ensure good image quality and no repetition. So radiographer say, oh, might as well I give more exposure. So if I give more exposure, if it is black, I can correct it. But if I give less exposure, I cannot correct. Or if I give lower exposure and my film come out as white, then I have to repeat. So lebih baik lebih daripada kurang. That's why in digital imaging, it is always happen and still happen. Okay, so higher dose radiation is actually disposed to the patient. So in Professor K.H. Ng in 2012 actually already say that overexposure issue in digital radiography imaging, while the digital techniques have the potential to reduce patient dose, they also have the potential to significantly increase them. Okay. And he also added that most radiation safety issues in clinical digital radiography for the radiographer's factor is actually inappropriate exposure and no or inadequate collimation. Okay, these two factors is actually the most issue in digital imaging. Okay, because we know that digital images, repeated images can normally go deleted. Okay, we can delete before it sent to the PACS system. However, these days there are some improvement of the machines made to the modality where they have the dose awareness software, where if you crop the images, the raw data is still can be seen. So we would know who actually our radiographer who actually crop the images and send the good images, the well collimated images to the PACS system. So, talking about the collimation, I will show some example here, what we see and what we don't. Okay. The first example here, we will see this is the PA erect chest radiograph. We can see here there is a good images. It has optimum contrast and density, and it is well seen. All the structures that we need to see are inside the collimation. But when we see the raw image, here, what we don't see is actually post-examination cropping. Yeah. So we can see here, actually, this is over collimated or not collimated at all. We can see other structure that we don't want actually in the raw image. Okay, this is the cropping or post-examination collimation. We actually the machine actually is built with the collimation itself, so that we can collimate to reduce dose to the patient. But in a lot of cases, this is what happened. Another example, this is a baby, maybe in the special care unit. We can see the chest X-ray, AP chest X-ray. Maybe this is a mobile X-ray in the ward. We can see here lungs, okay, well seen. All the images, all the structures we want to see is in the image. But sadly, to know that the raw data or the raw image is actually no collimation at all. Okay, so it is very pity and very sad to know this is actually a babygram. Okay, but we the radiographer do the proper collimation and send only the good images to the PAC system. So this is a poor collimation, large area of body irradiated, and digital cropping. Okay, post processing cropping. So in a journal, Pediatric Radiology in 2011, actually did a survey of 450 technologies by the American Society Radiology Technologies, SRT, revealed that half of the respondents is actually using the electronic cropping after the exposure. Okay, half of the participant in the study is actually crop after the collimation done after. It's not a collimation, actually it's a cropping. Okay, post-processing cropping. So there is actually a more radiation given to the patient. More examples here. Okay, cropping after examination. For me, it is not fair to expose like this unless this is a babygram. So please collimate your examinations before the exposure. More examples here. This is a pelvic X-ray. We can see here image in the PAC system is well collimated for the pelvis area. But in the raw data or raw image is actually no collimation, and the area of unnecessary radiation actually exposed to the patient. More examples. This is a femur, okay, right femur. Same thing also. This is actually a cropping, okay. And we know that patients, let's say for this image, for this case, maybe this patient have some POP or back slap in this patient. And this patient will come for the follow-up very regularly, and just imaging every time patient come and we just expose without gauntlet shield, and this will have a lifetime effect to the patient actually, especially the pediatrics. So what we need to do, optimizing but not compromising. So need to balance between the benefit and risk, and give the right dose and not to compromise the image quality. Of course, we want to give a lower dose as possible, but we will need to produce the good quality image. So basic of optimization, we need to give a good beam, no artifact, we give shielding, we give immobilization and collimation, and structures that we need is in the ROI. Okay, so the factors affecting the patient dose is actually many factors: beam quality, entrance dose, ESD or ESE, distance, SID, body part of the organ exposed, and area of the entrance beam. So I would like to share here some key optimization approaches. We need to only include the necessary anatomy, give the appropriate techniques, no grid if the part is less than 10 cm or in pediatrics, use collimation to decrease patient exposure and as well as increase the image quality, and use of AEC to lower the dose and standardize the dose, but not in the small children. Okay, talking about the collimation, I would like to show some practical guides, practical guides that we can use for radiographers in this related issue. The proper exposure, collimation, FFD or SID, use of proper shielding, immobilization, observe the patient throughout the procedure so that we don't expose while patient is moving, limited numbers of view, and use proper film screen combination if in analog system. Okay, I would like to show here what the effect of collimation with the image quality. It is very significant and a lot of study done for the collimation here. So when with the collimation, we actually reduce the patient's dose. The total volume of the body tissue irradiated is reduced with an appropriate collimation, and it's actually improve the image quality because it has the amount of the scatter radiation is reduced. Okay, let's see one study here regarding the collimation, image quality, and the dose. This radiograph, this study done to check the collimation, image quality, and dose. This radiograph is exposed 4 times using the 70 kVp and 3 MAS. But the lateral collimation is put as 43 cm, 20 cm, 10 cm, and 5 cm respectively. So as the collimation is narrowed, we can actually visibility of the spine is actually very much improved. You can see it here from the white or blurred image of the spine here. When we collimate, we actually can see the density and contrast very well. So always minimize the amount of the scatter radiation by doing the collimation. Here is another example. This
5 minutes left.
All right. Finishing. Thank you. This is also example of collimation, and this is not using the lead cover. Normally we do the lateral spine, we do use the lead cover. This is not using the lead cover, just the collimation. Okay, technique number 2 is entrance skin dose. Okay, this is to show you that using the AEC with 60 kV to the 81 kV, the dose is significantly reduced up to 35% of entrance skin exposure. Another way is to increase SID. This is study done by lecturer and student of UNISA that just recently published. This is also actually significant reduced when we increase the FFD from 100 cm to 130 cm. This is also regarding SID and ESD. It's actually using the high KVP, using the SID 40 and 48, it will reduce about 48 of those. Okay, and other methods is actually can reduce noise. We can also use the EI index. Some machine has this to guide us with the relative exposure intensity. And we know that Alara principle will remain the key method using the determine the proper exposure techniques for a given examination, and the technology and the methods of used to achieve this will continue to evolve and improve from time to time. So we hope that we have some improvement how to improve the patient safety in terms of radiation protection. So take home message, patients' radiation dose should be kept as low as possible. However, it will jeopardize the image quality significantly. So an ideal balance between patient dose and image quality should be achieved. Okay, so this is my references. We actually have celebrated our WRD Day in Hospital Uniza recently last week on 8 November. We have some activities going on here. So this is our day just to share the event that we do with involvement of the radiographers and the students. Okay, with that, I end my session today. Thank you very much, and a bit sorry for the unexpected error just now. Thank you very much. Over to you, Mr. Harris. Thank you.
Yeah, thank you very much, Wan Aziza. What a wonderful presentation. So, ladies and gentlemen, in short, from the presentation of Wan Aziza, we can see that digital imaging brings advantages in terms of image quality, image processing, and image communication. But in another way, it potentially increased the patient dose due to the overexposure factor, overcollimation. So therefore, optimization is needed by using strict collimation, increasing SID, high KVP technique, using proper equipment, and using image optimization software. So the next is we are going to Q&A session. There are questions from Pigeonhole. We can see there are 1, 2, 3, 4 questions. Maybe the first one from Rambu Zahrani. Rambu Zahrani is our student one. You said that many people think that more collimation is better than less. It is a wrong mindset, right? So how to change that wrong mindset about collimation?
Okay, thank you for the question. Okay, for me it's very easy. Okay, the more radiation you give is the more can I say unethical because the radiation we know that it is our job is to do the X-ray and to protect the patient as well, okay, as well as ourselves. So for me, actually, I already also remind my student during I'm also a lecturer in all this. If you you actually need to collimate as close as you can, okay, that is actually one of your technique that being teach. And for me, one tips is actually, I always think that the patient is our relative, our like mother and father, right? So we actually want to give more benefit and want to protect them. And for Muslim, is actually one words that I once gave to my patient. Just imagine that the more radiation you give to your patient is actually sin, a dosa, because you give more than you actually needed to give. That is what I can answer, give some suggestion. Hope that answer your question.
Yeah, that is the most simple way. Think that or imagine that the patient is our family, right?
Yes.
Okay, but sometimes the radiologists ask more collimation. For example, for lumbosacral spine, radiography, but the radiologist ask for full abdomen collimation. How we
if
meet the radiologist and the strict collimation?
Okay. Radiologist is actually need to understand our scope or our techniques. Okay. If you want to see the spine, then the techniques, the actual technique is to collimate until the like the lateral transverse process. But if you want to see the abdomen, then the actually that is the imaging request is actually depends on the what indication you want to see. Okay, so what if you want to see the abdomen, then it should be indicated to request for the abdomen. But when you say you want to see the spine, but you want to do abdomen, what is the indication? What is the justification of you to open the collimation until the abdomen, right? But in some cases, like the patient have actually the doctor want also to see the spine as well as the abdomen, then it actually need to put in the indication that this patient, I want to see the spine and also the abdomen. So we can do it one, just abdomen, and all yours, you want to see the abdomen or you want to see the spine, it is all there, right?
All right.
Okay.
So we have to go back to the indication.
Yep.
The next question about regulation one from Muhammad Ashraf. It is also our student. How are radiation safety guidelines and regulations established, and how do they vary across different industries and regions?
Good question.
You can share or tell to us how the regulation related to the radiation dose in Malaysia.
Okay. This is very out of the box question. Thank you for the question. Okay. The radiation safety guideline is actually actually each country has the board. Okay, like in Malaysia we have the Atomic Agency AELB Atomic Agency Licensing Board. And the license, each country radiation protection board is actually have one reference that is the IAEA. So we actually, all the countries is must refer to the world or to the global organization that is the IAEA. So every regulation is actually come from the IAEA and come to the country. Okay, that is what I know. So each country that is they will have the guideline and the regulation that suited the country itself. So for that's why the board or the licensing body need to control and give regulation and have some we say penguatkuasaan. If you have some mischieving or whatever, then the punishment or the law the Act in Malaysia, we call it Akta 304, 304, is very strict. You cannot come across, you cannot pass anybody that you want to get license from. This is very, very strict. So that is how the radiation protection or radiation regulation guide, so that we have a safe use of radiation, especially in medical.
All right. Yeah. Mostly it is adopted from the international regulation, right?
Yep.
Okay. Maybe one or two more question. This is from Nurlaila Triunita. In some X-ray equipment, there is AEC. Is it good enough to optimizing those radiation, or is there any other tips to combine that AEC to optimizing those radiation? Maybe how effective the IEC to minimize the radiation.
Okay, we know that AEC is automatic exposure control. So we actually can give some suggestion KVP, let's say, we give one KVP, and the system will calculate what is the dose needed, and the system will cut off when the density is adequate. So this is actually one way to control the exposure, so that we don't give overexposure or unnecessary exposure. This is actually good. I mentioned in my slide just now, one of the way to the radiation protection or to optimize the radiation dose is actually using the AEC. But the AEC, with using the AEC, you need to very particular about your centering, about your chambers, you know, because if you're not particular in that, you will end up not giving a good radiograph. So is there any tip to combine an EC to optimize dose? Yes. Like I said just now, when you use the AEC, you need to be very good in position, where correct KVP, or nowadays they already like AEC that you don't need to choose either KVP, also you don't need to choose, then you just put the program and you just expose, and the system will select the KVP and MAS for us, right? There is system like that. But normally we actually choose KVP, and the MAS will be automatically controlled by the machine. And using AEC and combined with the good technique, good chambers, good selection of the chambers, that is matters actually in using AEC.
Okay, so using AEC is helpful enough in optimizing the dose, but unfortunately not all the equipments with AEC. Yeah, so maybe continue to the next question. Yeah, beside the IEC, what steps can be taken to optimize procedures and minimize radiation protection to patients while maintaining diagnostic image quality from Septian Eka? Maybe based on your experience or your opinion, which technique or which way is the most effective way to reduce patient dose?
Okay, I actually put some suggestion just now. One is use AEC. Another one is you can increase the SID from 100 cm to maybe 130. Another one, you can use high KVP, because we know when we use the high KVP, the MAS will be low. So the MAS is actually using the dose to the patient. Okay, that is a few way lah, method to reduce the radiation dose to patient. Okay.
Yeah. I think the question and answer session is enough, and then we move to the next agenda. But before we continuing to the next agenda, I would like to inform to all of the participants that Puan Aziza is also a book writer, and maybe in this occasion, she will promote her work. Please, Miss Puan Aziza, to share your books.
Okay, thank you very much for the opportunity. I actually okay, right, let's share. Okay, let me share my screen, yeah. Okay, actually I have a small contribution. Actually, this is my two ebooks that I wrote earlier. One is in 2021 and one is last year. So the first book is Terminologi Perubatan Panduan Mudah untuk Pelajar. This is actually what I did when I was in the Faculty of Health Science of UNIZA. Because I found that medical terminology is very hard to digest, right? There is so many terminology that we don't know what is the meaning, etc. So I actually make this book for students, especially for students, but radiographers also can see. It actually dua bahasa, the dual language, English and bahasa Melayu, but I think bahasa Indonesia also boleh faham kan. So another book is about the pathology, radiographic pathology. I put some radiographic appearances, signs, how do like TB look like, how do so many pathologies here. So this book actually can be bought at my bookstore here. You can just click the link here and it will go to the page. You can actually preview the book first. It will give you the first 10 pages of the book for you to review. And if you think the book is suitable for you, then only you buy for it lah. That is the advantage of the system, this platform. This book is actually I put it as a very easy approach, like contohnya perkataan A minoria, contoh A minoria. So I put that a way to like easy to understand and easy to remember. So like I put the suffix, the awalan dan itu akhiran. Jadi contohnya dalam case A minoria, so I put A. What is A mean? A mean absent. So minor, what is it mean? So we also have the akhiran of the words that we need to know, so that when every time we see the words, then we will like easy to remember and easy to relate. Okay, so I would like to expand my use of this ebook to rakan-rakan pelajar dan juga lecturers in Indonesia. So I hope it will benefit your student and faculty there. That's all. Thank you very much for the opportunity to promote my book here.
Yeah, that is
Thank you.
interesting work. Yeah. I hope in the future we can collaborate to produce more books.
I love to. Okay, thank you.
Madam Aziza or Puan Aziza, next we would like to invite you to accept the certificate or sijil, right? In Malaysia, it's called by sijil.
Sijil, yeah.
Yeah, from the Department of Radiodiagnostic and Radiotherapy Technique, that is represented by the Secretary of Department. To Mr. Nanang Sulaksono. Can you give the certificate?
Okay, thank you, Mr. Garis. The Honorable Puan Aziza from UNIZA Malaysia, we would like to say thank you for attending and witnessing this important event IConTRAS. And also we would like to say thank you for the next presentation that give to you. So this is the certificate for you presentation today. I hope this activity is beneficial for everyone. Thank you, Wan Aziza.
Thank you. Saya mau address apa ya Pak Nanang ya.
Ya, Pak.
Terima kasih di atas sertifikat diberikan ini. Saya sangat honored to be in this event actually. Thank you very much for inviting me, and I would like to congratulate also the organizer for your first IConTRAS event happening today. Thank you very much.
Yeah, thank you, Mr. Aziza.
All right,
Thank you.
thank you very much to Mr. Nanang, and once again, give a big applause to Wan Aziza. Thank you. Hopefully, in the next occasion, we can collaborate, in the lecturer or in the book writing. See you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih.
And all distinguished participants, for the second, I would like to invite Mrs. Dartini, Sarjana Kesehatan Masyarakat, Magister Kesehatan, that will deliver an interesting topic entitled Patient Safety in Indonesia. Yeah. But before starting this session, allow me to convey a brief CV of Mrs. Dartini. She is lecturer in the Radiodiagnostic and Radiotherapy Technique Department, Poltekkes Kemenkes Semarang. She was born 53 years ago, graduated from Semarang Radiology Academy in 1992, finished her Master of Public Health at Diponegoro University in 2007, and recently she is going on her doctoral study at State University of Semarang. She has about 28 years of teaching experience, and she has a strong background in public health and occupational health and safety. Without further ado, please welcome Mrs. Dartini.
Assalamualaikum warahmatullahi wabarakatuh. The Honorable Director of the Health Polytechnic Ministry of Health Semarang, Mr. Jeffrey Adrianto, Master of Applied Science, the Honorable General Chairman of the Indonesian Radiographer Association, Mr. Dr. Sugianto, Sarjana Pendidikan Master of Applied Science, the Honorable International Radiology Webinar Speakers, the Honorable Head of the Department of Radiodiagnostic and Radiotherapy Technique of the Health Polytechnic Ministry of Health Semarang, along with the Secretary of the Department and Head of the Study Program, the Honorable Ladies and Gentlemen, lecturers, and all international webinar participants. Thank you to the moderator on the time given to me. Here, I will present the topic of patient safety in Indonesia. Background on patient safety, namely, patient safety become a global issue. 5 important issues consist of patient safety, safety of worker or health worker, building and equipment safety, environmental safety, safety business. And then patient safety come first. Undesirable events are increasing. The incident in Colorado was 2.9% and 6.6% day. In Indonesia, there is no data, but the incident of malpractice has increased which was proven later. What is patient safety in hospital? 3 hospital quality elements consist of input, process, outcome. And then hospital service standard. Number 1, quality assurance, total quality management, continuous quality improvement, licensing, accreditation, credential, medical audit, clinical indicator, clinical governance, and ISO. The above standard aim to improve services in the aspect of input, process, output, and outcome. But in reality, undesirable events still occur. So it is necessary to have a program to anticipate undesirable event, which is then known as patient safety. With the patient contention, the public trust in hospital increase. The possibility of conflict between doctor or healthy worker and the community decrease. Next, I will explain patient safety. Patient safety is a system consisting of risk assessment, identification, and management of patient-related matters, incident reporting and analysis, the ability to learn from incidents, and their follow-up and implementation of solutions to minimize the emergence of risk. Under definition, patient safety is a system that makes patient care safer, including risk assessment, patient risk identification and management, incident reporting and analysis, learning ability from incident and their follow-up, as well as the implementation of solutions to minimize the incidence of risk and prevent injuries caused by errors to the carrying out on action or not. Taking action that should be taken by the patient in this appropriate Permenaker number 11 of 2017. Patient safety objective: to improve the quality of services of health service facilities through the application of risk management in all aspects of services provided by health services facilities. Patient safety standard refer to hospital patient safety standard issued by the Joint Commission on Accreditation of Health Organization, earlier USA, in 2002. Patient safety standard must be implemented in the hospital and assessment are carried out using hospital accreditation instrument. Hospital patient safety standard consists of patient rights, educating patient and family, patient safety and continuity of care, use of performance improvement methods to conduct evaluation and patient safety improvement program. Leadership role in improving patient safety, educating staff about patient safety. Communication is key for staff to achieve patient safety. Referring to this standard, hospital must design new process or improve existing process by identifying data, evaluating data, and intensifying analysis and expected event to improve performance and patient safety. We use 7 patient safety topic. 7 step to hospital patient safety consists of build awareness of the value of the patient safety, lead and support your staff, integrated risk management activities, develop a reporting system, engage and communicate with patients, learn and share experience about patient safety, prevent injuries through the implementation of patient safety system. Next, instruction for implementing patient safety consists of preparation phase, implementation phase, and evaluating phase. Preparation phase consists of establish short-term hospital patient safety plan policies and annual program, establish a responsible work unit that manage hospital patient safety, select the training force that will be the training force for hospital patient safety and training, hospital patient safety pocket book. And then implementation phase consists of declaration of the moral movement of patient safety, 7-step patient safety program, patient safety accreditation standard implementation program, patient safety program in specific unit as model, specific program, and discussion forum. And the last, evaluation phase, monitoring and evaluation carried out frequently. Monitoring and evaluation come out critically to improve the program. Implementation of patient safety in Indonesia. Monitoring the implementation of patient safety is carried out by an independent body as a hospital accreditation. The implementation of patient safety can be configured according to the table below, which consists of correctly identify patient, improve effective communication, increase the safety of alert medication, ensuring the correct surgical location, the correct procedure, the correct surgical on the correct patient, reduce the risk of healthcare-related infection, reduce the risk of patient injury due to fall. This table consists of goal, aim, and objective implementation in radiology. Specific collective identification. Misidentification of patient can occur in all aspects of diagnosis and action. Ensure the accuracy of the patient who will receive the service of action to align service or action required by patient. This element correctly identify patient consists of 5 number. Number 1, there are regulations governing in the implementation of patient identification. Patient identification is carried out using at least 2 identifiers and must not use the patient room number or the location of the patient being treated in accordance with hospital regulation. And 3, patient identification is carried out before procedure, diagnostic and therapeutic procedure are performed. Patients are identified prior to administration of drug, blood product, specimen collection, and diet procedure. And the last, patients are identified prior to radiotherapy, receiving intravenous fluid, hemodialysis, blood drawing, or the other specimen for clinical examination, cardiac catheterization, diagnostic radiology procedure, and identification of comatose patient. Implementation in radiology confirm the patient identifier, name, age, address, medical record number before the examination. Number 2, making staging according to the set of the body part, confirm the patient history before examination using contrast media. And number 2, improve effective communication. Communication is considered effective when it is timely, accurate, complete, not ambiguous, and received by the recipient of information aimed at reduce error and improve patient safety. To communicate verbal or by telephone safely, the following are done. Number 1, medication or verbal request for medication should be avoided. In an emergency where written or electronic communication is not possible, guidelines must be established, include the request for explanation, receipt of the result of the explanation in an emergency, identification and determination of critical value, diagnostic explanation result, and the result of critical check are report. This element, there are regulations on effective communication between caregiver professional. 2. There is evidence of effective communication training among caregiving professional. Verbal telephone messages are written in full, directing the receiver of the message and confirmed by the messenger. Implementation in radiology, example, explanation of inspection procedure before explanation, explanation of the patient preparation before the explanation, written explanation of assignment, read radiographic explanation request carefully. Number 3, increase the safety of high alert medication. Every drug, if incorrectly used, can endanger the patient. Even the danger can cause death or disability of the patient, especially drugs that need to be wary of. Drugs that need to be washed out of are drugs that contain an increased risk. If we use the wrong one and can cause great harm to patient. Drug to wash out composite of high-risk drug whose names, package, label, critical use, look alike, sound alike, such as Xanax and Zantac, Pasitrazalanin and hydroxyzinin are also called similar speech drug names or norum. Medication error around the world, the causes of the are insufficient knowledge of the name of the drug. There are new products, some packaging and label, clinic indication are the same. The form, doses, and rules of the use the same. There was misunderstanding when giving orders. This element, there are regulations. Number 2, the hospital implementation, the regulations that have been made. Number 3, in the hospital there is a list of all drugs to wash out of which is compiled based on the specific data is accordance with regulation. The storage, labeling, and the storage of drugs that need to be washed out of, including no-room drugs, are regulated in the safe place. The hospital established regulation to implement the process of preventing carelessness in the administration concentrated electronic and then concentrated electronic in only available. Implementation in radiology example, setting up contrast media according to the type of examination, prepare the volume of contrast media according to the patient condition and which, and then preparing anti-allergic drug, and the last, monitor the patient conditions before, during, and after the examination using contrast media. And number 4, ensuring the correct surgical location, the correct procedure, the correct surgical on the correct patient. This error occurs, among other things, as a result of ineffective, inadequate communication between team members, no patient involvement to ensure the accuracy of the operation set, and no procedure for verification, incomplete patient assessment, incomplete medical record, a culture that does not support open communication between team members, problem associated with illegible, unclear, and incomplete reading, no standard, and prohibit use of abbreviation. Implementation in radiology, example, provide the radiograph according to the experience, the abnormality by providing the correct marker. Provide marker to assess injury, example, foreign body. This element for instance the number 4 consists of 7 number, and then number 5 reduce the risk of healthcare related infection. This element 5 number, they are regulation and hand hygiene guidelines that refer to the last WHO standard. The hospital implemented hand hygiene program through the hospital accordance with regulation. Hospital staff can wash their hands according to procedure. There is evidence staff carry out with hand washing moment. Disinfectant procedure in hospital are carried out in accordance with regulation. And implementation in radiology, example, make effort to prevent nosocomial infection. Wash your hands before and after carrying out examination. Clean examination tool regularly using disinfectant liquid. Kemudian, next, use standard personal protective equipment. And number 6, reduce the risk of patient injury due to falls. Various factors that increase the risk of falling patient include patient condition, functional impairment of the patient, the location of situation on the hospital environment, patient fall history, consumption of certain drugs, alcohol consumption. Implementation in radiology, example, monitoring patient during examination, preparing a conducive experiment, carry out radiation protection correctly, do not repeat photo, do not repeat radiograph, provide personal protective equipment for patient, deliver patient. This topic reference this Permenkes, Panduan Keselamatan, CCA, Desain Hospital, and SNAR. That is all I can say. Thank you. Next time, we will hand it over to the moderator. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Applause for Mrs. Dartini. An interesting topic that, in short, I can conclude that patient safety is a global issue. In Indonesia, there is regulations that standardize the patient safety implementation. The system to ensure patient safety consists of how to manage the risk, how to build the commitment, how to organize the personnel and procedures, and how to monitor and evaluate the system. To establish it, collaboration is needed among the patient family, staff, and also management. Ladies and gentlemen, now we are going to the Q&A session. I would like to check from the pigeonhole. Okay, maybe the committee, would you help me to find out the question? Is there any question from the pigeonhole? Or maybe I invite the participants to give question by live
Ada satu
session.
Mas Haris. One question.
Okay, one question from pigeonhole. All right, Bu Dartini, there is one question. How can healthcare providers communicate effectively with patients about radiation risk, especially in situations where repeated imaging studies may be necessary? Ya, jadi bagaimana mengkomunikasikan dengan efektif terhadap pasien tentang potensi resiko akibat radiasi yang diterima, khususnya di pemeriksaan-pemeriksaan yang membutuhkan lebih dari satu proyeksi mungkin kurang lebih. Silakan Bu Dartini.
Thank you, Mr. Haris. Mohon maaf, saya mau jawab pakai bahasa Indonesia saja. Ini yang bertanya siapa, Mas Haris? Dari mana? Mahasiswa?
Question is from Dimas.
Baik, terima kasih. Bagaimana caranya dari provider atau pemilik pelayanan untuk menyampaikan ke, mohon maaf, suara saya bisa terdengar?
Iya Bu, jelas Bu.
Oke. Mengkomunikasikan tentang prosedur pemeriksaan radiografi yang membutuhkan lebih dari satu pemeriksaan. Di dalam step-step yang tadi saya sampaikan, ada yang komunikasi efektif, di mana salah satu tugas dari radiografer yang merupakan perpanjangan tangan dari pemilik pelayanan harus menyampaikan penjelasan prosedur pemeriksaan yang akan dilakukan. Disitulah momen atau waktu yang harus dilakukan oleh penyedia pelayanan, terutama radiografer, untuk memberikan penjelasan terhadap pasien bahwa prosedur yang akan dilakukan itu adalah ada beberapa kali ekspos, dan itu hukumnya adalah wajib, istilahnya hukumnya adalah wajib, ya. Karena kalau misalkan tidak dijelaskan, karena secara prosedur urutan dari tahapan-tahapan pemeriksaan, pertama kali pasien datang adalah konfirmasi identitas, di mana konfirmasi identitas itu dia bisa berdasarkan hanya nama saja, tetapi harus berdasarkan nama, umur, nomor RM, dan satu lagi ditambah dengan alamat. Karena apa? Nama bisa sama, umur bisa sama, tetapi alamat biasanya tidak sama. Kadang-kadang kalau berkaitan dengan nomor, pasien tidak hafal. Kalau di Indonesia seperti itu, sehingga harus ada tanya alamat. Itu yang benar. Kemudian yang selanjutnya adalah menjelaskan apa yang akan dilakukan. Disitulah kesempatan atau waktu yang tepat untuk menjelaskan ke pasien bahwa prosedur yang akan dilakukan adalah beberapa kali. Mungkin itu Pak Eris, jadi memang harus dilakukan penjelasan sebelum pemeriksaan, salah satunya adalah berapa kali ekspos yang akan dilakukan. Terima kasih.
Baik. Baik, jadi so the informed consent is an important step to be performed in every medical procedure, including radiography examination. And one part of the informed consent is we have to inform the patient every detail about the examination, including the risk and benefit. Okay, maybe next question. Okay, there are 1, 2, 3, 4 questions. Maybe from Alia. What guidelines and protocols are in place to ensure the safety of pregnant patients undergoing medical imaging or radiation therapy? Baik, jadi pertanyaan berikutnya Bu dari Saudari Alia Akila. Apa guideline atau protokol yang bisa digunakan untuk memastikan bahwa pasien-pasien yang sedang mengandung dan menjalani pemeriksaan atau terapi ini aman, Bu?
Terima kasih Pak Aris, terima kasih Mbak Alia. Jadi untuk pasien-pasien yang posisi hamil, dilakukan tindakan pemberian radiasi itu sudah banyak pertimbangan. Sudah dipertimbangkan secara matang oleh dokter yang mengirimkan. Sehingga apa yang harus dilakukan atau aturan-aturan apa, lakukan prosedur sesuai dengan SOP yang benar. Contoh, apabila dilakukan pemeriksaan bukan di daerah abdomen, harus ada proteksi, pemberian proteksi, faktor eksposi juga diatur, apalagi dengan tadi yang disampaikan oleh asisten itu bahwa ada upaya untuk optimisasi dari faktor eksposi, itu yang harus dilakukan. Bagaimana caranya mengatur faktor eksposi yang aman bagi, ya bukan aman, tetapi pada prinsipnya adalah yang seminimal mungkin untuk pasien hamil, tetapi hasil yang dihasilkan, radiografi yang dihasilkan adalah masih informatif. Kemudian jangan sampai, ini harap diperhatikan, jangan sampai mengulang radiograf. Itu sangat penting sekali khusus pasien hamil dan juga untuk yang lainnya sebetulnya. Tetapi pada prinsipnya dokter mengirimkan atau membuat permintaan foto pasien ini adalah sudah dipertimbangkan dari manfaat dan efeknya. Seperti itu. Prosedur yang dilakukan harus sesuai dengan prosedur bahwa harus melakukan proteksi radiasi terhadap pasien tersebut. Gitu Pak Aris.
Baik, terima kasih Bu. So, the justification is really needed before the patient is undergoing the examination. So doctor will decide is it really need to expose the patient or not. And if the examination of radiology is needed, so optimization must be implemented by selecting the exposure factor, technique, etc. Okay, next we are moving to the next question. Okay, maybe this one. Not this. From the Werima. Yeah. Baik, selamat siang Bu Dartini. Saya saat ini bekerja di Rumah Sakit Hewan di Jakarta. Ya, saya ingin bertanya, tips dan trik untuk menentukan faktor eksposi untuk objek yang akan saya periksa. Ya. Alright, I think this one is out of the box question, from veterinary radiology, in Jakarta. How to define the correct, exposure factor for animals?
Baik, terima kasih Mbak Karima. Jadi tip dan trik dalam kondisi situasi dan kondisi apapun untuk penentuan faktor eksposisi dasarnya adalah satu keadaan atau kondisi dari objek. Ketebalan, kerapatan itu adalah pertimbangan yang harus dipertimbangkan. Kondisi yang harus dipertimbangkan. Contoh, ketebalan objek. Hewan itu kecil, besar, tebal, tipis, itu sebagai pertimbangan untuk menentukan faktor eksposi. Kemudian yang kedua dari sisi kerapatannya, objeknya itu
kerapatannya tinggi atau rendah. Itu juga sebagai penentu untuk penentuan faktor eksposisi. Jadi sama saja antara manusia dan hewan sebetulnya Mbak Merima. Jadi sama saja, jadi tidak ada perbedaan. Selama objeknya itu tebal, kerapatannya tinggi, faktor eksposisi mesti tinggi. Selama objeknya kecil, faktor eksposisinya kecil. Selama objeknya tebal dan misalkan contoh kayak di daerah torak hewan, itu kan berarti kita tujuan untuk melihat apa? Selain itu juga tujuan untuk melihat apa? Soft tissue atau tulangnya. Jadi pertimbangan faktor yang ditentukan adalah tadi dari sisi ketebalan, kerapatan, tujuan dari objek yang akan difoto tersebut. Itu sebagai pertimbangan pada saat menentukan faktor eksposisi. Itu Mbak Merima. Mbak Merima, terima kasih.
Terima kasih Bu. So Mbak Werima, it is the same with the human. We use the principle of the thickness and object density and atomic number in defining the correct exposure factor. But maybe this one is about animal safety, not patient safety. Okay. Okay, we move to another question. Okay. This one is from Septian Eka. Question from Septian Eka. Can you explain the concept of justification in the context of medical radiation exposure and its significance for patient safety? Baik Bu, berikutnya pertanyaan dari Septian Eka. Dapatkah Ibu menjelaskan konsep justifikasi dalam konteks exposure pada medis dan signifikansinya terhadap patient safety? Jadi mungkin dibanding dengan resiko-resiko lain, resiko jatuh, resiko salah obat dan sebagainya, seberapa signifikan bahaya atau resiko akibat radiasi ini?
Oke. Terima kasih Mas Septian Eka. Jadi kalau kaitannya dengan risiko radiasi, Mas Eka sudah tahu kalau secara langsung tidak ada. Secara langsung tidak bisa dirasakan, bukan tidak ada, tidak bisa dirasakan oleh pasien. Sehingga memang kadang-kadang hal itulah yang jadi kita kadang-kadang kita sendiri malah justru yang melalaikan, lalai ya, karena memang tidak bisa dilakukan. Tapi kalau pasien jatuh, salah obat, alergi langsung bisa ada efek yang bisa ditimbulkan. Tetapi kaitannya dengan efek radiasi itu tidak secara langsung. Merasakan aja saja tidak, merasakan saja tidak. Misalkan contoh, apakah sehabis diekspos kemudian merasakan panas, dingin atau bagaimana? Enggak. Kalau suhu yang panas jelas kita jadi berkeringat. Tetapi kalau radiasi kan enggak. Dengan faktor eksposisi standar yang digunakan pada pemeriksaan radiografi tidak bisa dirasakan sama sekali oleh pasien kaitannya dengan efeknya. Tetapi kenapa kita tetap harus melakukan patient safety? Karena secara ketentuan bahwa pasien itu menerima radiasi harus sesuai dengan yang harusnya dia terima, tidak lebih, tidak dikasih bonus, ibaratnya seperti itu. Kalau ada sesuatu yang memang menguntungkan kasih bonus senang, tetapi kalau radiasi jangan diberikan bonus untuk pasien. Sehingga tadi faktor eksposisi yang optimal, tidak mengulang foto, memberikan alat proteksi radiasi bagi pasien sesuai dengan kebutuhan, dalam arti jangan sampai alat proteksinya malah menutupi objek yang difoto. Itu adalah hal yang wajib bagi seorang radiografer dalam memberikan pelayanan terhadap pasien dalam rangka untuk pasien safety. Itu Pak Haris.
Terima kasih Ibu. So Mas Septian, the concept of justification, in simple way, we have to make sure that the benefit is greater than the risk, and the effect of radiation is not real time. It is silent but scary. Okay. Is there any more question from the pigeonhole? Finished? All right, ladies and gentlemen, we would like to say thank you to Ibu Dartini and we invite you to accept the certificate from the Department of Radiodiagnostic and Radiotherapy. In this occasion, Mrs. Dwi Rohmayanti, as head of study program, will give the certificate. Please welcome Ibu Dwi Rohmayanti.
Selamat siang.
Okay. Can you hear my voice?
Okay, clear.
Okay. Thank you for sharing knowledge here on behalf of the Department of Radiodiagnostic and Radiotherapy Engineering. I express our appreciation to Mr. Dartini. Along with this, we present a certificate to you. May the committee present show the certificate.
Thank you.
Yeah.
Miss Dwi
And
Rohmayanti.
hoping
Success.
for the blessing of your knowledge, and once again we convey our thanks.
Okay, thank you. Success for all.
Right. Thank you very much to Mrs. Dwi Rohmayanti and Mrs. Dartini. Once again, give a big applause to Mrs. Dartini for a wonderful presentation. Okay. Ladies and gentlemen, we are now in the end of the first speaker session. As moderator, I apologize for any mistakes and inconvenience. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. We would like to express our gratitude to Puan Aziza Abdul Ghani, Bachelor of Science, and Mrs. Dartini for the amazing presentation, and to Mr. Ahmad Haris Sulistiadi, Sarjana Sains Terapan Magister Kesehatan, who has guided the presentation of the first material session.
Distinguished guests, this event can be held because of support from many parties. One of them is Fujifilm. On this occasion, Fujifilm will provide a little about technology updates to all of us. For that reason, let's watch together the technology update from Fujifilm.
Daya pikir ilmiah kami untuk mengubah dunia. Kami memprakarsai fotografi digital dan kamera instan yang melestarikan kenangan dan memperkaya kehidupan. Tapi mengapa berhenti di situ saat ada begitu banyak cara dalam berinovasi untuk dunia yang berkelanjutan? Dalam layanan kesehatan, kami merevolusi diagnostik dengan menerapkan teknologi AI ke berbagai solusi, mengoptimalkan baik alur kerja klinis maupun IT. Portfolio unik kami yang juga mencakup sistem MRI dan CT memanfaatkan teknologi pencitraan dengan tujuan mendeteksi penyakit lebih dini dan mendukung dokter dalam memberikan perawatan berkualitas. Tapi mengapa berhenti di situ? Saat kami bisa menerapkan keahlian kami dalam nanoteknologi dan teknologi eksklusif lainnya dalam menangani penyakit menular dan kebutuhan medis yang belum terpenuhi. Kami berkontribusi pada kemajuan medis mitra kami dengan menyediakan material dan fasilitas pemrosesan khusus untuk pengembangan obat-obatan dan vaksin. Tapi mengapa berhenti di situ? Saat kami juga bisa meningkatkan kesehatan planet ini. Solusi media penyimpanan data kami mengurangi emisi CO2 dengan secara drastis mengurangi kebutuhan energi pusat data. Dengan produk industri canggih, kami dan mitra kami mendukung inovasi bagi masyarakat digital. Dalam hal inovasi bisnis, kami menerapkan kemampuan AI dan IoT kami untuk mengatasi beberapa tantangan terberat. Dengan memanfaatkan printer multifungsi sebagai pusat layanan, kami mengubah cara mengatur, menganalisis, mengakses, dan mengamankan data fisik dan elektronik dan merevolusi cara menyelesaikan pekerjaan. Tapi mengapa berhenti di situ? Melalui berbagai industri, kami telah belajar untuk memanfaatkan dan menyesuaikan pengetahuan, keahlian, dan sumber daya kami untuk membuat dunia menjadi lebih baik. Dalam hal inovasi untuk dunia yang sehat dan kehidupan yang berkelanjutan, kami never stop. Fujifilm, value from innovation.
Ladies and gentlemen, the next speaker session will be guided by our moderator, Mrs. Maria Tuljana, Sarjana Sains Terapan Magister Kesehatan. Time is yours.
Thank you for the Master of Ceremony today. Good afternoon.
Good afternoon.
Welcome to the first IConTRAS International Conference on Technology of Radiology and Applied Sciences. I am Riha, and it is my immense pleasure to serve as your moderator. We are gathered here today, surrounded by the brilliant minds from across the globe, to explore and discuss the latest trends and updates in patient safety within the field of radiology and applied sciences. This conference marks significant milestones in our journey towards advancing medical technology and enhancing patient care. The theme, patient safety, trends and updates, reflects our collective commitment to not only embrace the latest technological advancement, but also to ensure that these innovations contribute to the safety and well-being of patients worldwide. Now, it gives me great pleasure to introduce our third keynote speaker, Professor Kanada Kumari Celia. Good afternoon, Prof. How are you?
Oh, good. Thank you.
My pleasure. Yeah. Ladies and gentlemen, allow me to convey a brief curriculum vitae of Professor Kanaga. Professor Kanaga Kumari Celia graduated with a bachelor's degree in medical imaging from Curtin University, Australia, and attained postgraduate qualification in education and medical physics. Prof. Kanaga so joins Asia Metropolitan University as the Dean of Faculty of Health Sciences on 1st June 2017. Prof. Kanaga is a Class H consultant with the Ministry of Health, ensuring necessary equipment safety standards. She is an expert in medical imaging for the Malaysian Qualification Agency, assessing program standards, and contribute to the Allied Health Sciences guidelines. Proven research, she has been the principal investigator for grants like Science Fund and RDS, publishing over 50 articles and book chapters. As a guest speaker, she has delivered keynotes at numerous conferences. Recognized for her teacher excellence, she has received multiple innovation awards and actively collaborates with NGOs on community projects. Today in this virtual settings, Professor Kanaga will enlighten us with her talk. So please, without further ado, welcome Professor Kanaga Kumari Celia. Time is yours.
Thank you, Miss Maria, for your kind words. Okay, a very good morning. I think it's still morning in Indonesia. Okay, to all the distinguished guests. And I would like to first mention my appreciation to the committee, Dr. Fatima, and all the committee for inviting me as a speaker today to share my knowledge in the first International Conference on Technology of Radiology and Science. Thank you very much. I will now share the screen and start with the presentation. Okay, I suppose Miss Marie Chatur, okay, our moderator, you can see my screen.
Yes,
Okay,
of
thank you.
course.
Okay, I will start with the presentation. I think you all have actually organized a webinar which is in line with the World Radiography Day, which was done on the 18th of November 2023, celebrating patient safety as a thing. So I'm very glad and pleased to present at this contrast in short, which is held today, 15 November 2023. So be just a memorable day, as is the first international conference. Okay, so I will go further. If there are any questions, I think you all can share. All right. Okay, let me now start off with the contents of today's presentation, the overview, safety concerns, safety issues, and I'll be talking about safety issues in radiography, CT, MR, radionuclide, radiotherapy, and of course the conclusion. Most of my experience, which I will be sharing, is the Malaysian scenario because I worked in the public hospitals, we call it. That's the government-run hospital in Malaysia. And then I also worked as in my CV in the public university, which we call Institusi Awam. And then now, after my retirement, I'm working in a private university. Okay, so let me now go further. All right, today's topic today is patient safety. Patient safety, patient is all of us are radiographers. Patient or whoever works in the health profession, the patient is the VIP or the most important person in the hospital, because without them we are jobless, right? Because we have nobody to treat. Okay, so safety, it means it's the absence of preventable harm and to a patient during the process of healthcare. This is the definition I saw in the dictionaries. Okay, let us now go further. Okay. All right. Patient safety, according to the World Health Organization, is the absence of preventable harm to a patient during the process of healthcare and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Okay, whereas patient harm is defined as an injury that was caused by medical management rather than the underlying disease. So the patient may have come for, say, an acute abdomen or an appendicitis. Definitely he has a abnormality or a pathology, but this harm is not due to his disease. Okay, and that prolong the hospitalization. He may contact with other infectious disease, okay, or his appendectomy, which was removed, what may become septic, due to not clean facilities in the hospital, okay, so then he has to stay longer. So definitely, or it produces a disability at the time of discharge or both. This is according to the Harvard Medical Practice Study. Okay, let us now move on to the facility safety. Okay, so as we know, I'm looking at the broader aspect, the whole hospital, because usually the X-ray department is located in a hospital or a clinic. Okay, so the hospital environment presents unique safety problems when compared with other industrial settings, like say car manufacturing. So their problems are different. They also will have safety issues, but it's different because we have our patient, our staff, and the caregivers. Sometimes the caregivers accompany the patient in the hospital. So they are kind of part of this whole organization. The causes of hazard fall into two broad categories. Failure of a device to correctly perform the desired function. In other words, could be we are pushing them on a wheelchair, and then a simple thing I'm telling, because in radiography we have these patients on wheelchair at the whole hospital. Okay, then the brakes don't work and the patients fall down. Okay, another typical thing we can say, which is quite drastic, is we have these patients who pediatric cases. Example, we actually put our X-ray tube, and we must make sure it's locked so that it doesn't fall on the pediatric. Why I say pediatric? Because pediatric patient will be very drastic compared to adults. So these are a lot of safety issues we have to be careful. So failure of hospital personnel to correctly use the medical equipment. All right. The medical personnel must be familiar with the equipment. If not, we will also have problems. Okay. Okay, safety plan it indicates that the periodical inspection, maintenance, and calibration of all equipment. As we are actually working with, this is more into radiology, so we are working with very expensive equipment, all right? So it has to be maintained well, right? It has to be calibrated. And management of also for radioactive substance, for the management of radioactive material, particularly with regarding to handling, storing, and transportation. And hospital must, or the radiology department must have periodic quality control tests for automatic exposure control, KVP reproducibility, alignment, collimator, and many others where we do according periodically, 6 months, or like for DEXA, we may do it every day for calibration. All has to be done. Okay. And safety program. The hospital or the radiology department too must have a safety program. And it must have the three major components. What are the hazards and risks present in the department? And how do we prevent it? Okay. And anything you do must be documented. This is very important because in Malaysia we have the ISO and all this, whereby they will come and check in the hospitals all the documentation. Okay. The identification phase may be ongoing that can respond to new information. Okay, you keep on looking, you keep on identifying hazards and risks. So that's incident analysis. Elimination or direct contact of the hazard if possible, and supervision and education of the workers should be done. Inspection and preventive maintenance, replacement. As I said, PPE or preventive medicine is maintenance is good. And then replacement, changes in types of equipment, changes in procedure, the addition of safety and protective devices. And of course, we have to have continuous education for our workers or the staff so that they come updated with safety prevention. Okay, the documentation is very important. Whatever we do, it has to be documented because it's a record. It provides visual and concrete documentation to the accrediting or licensing bodies, such as the Joint Commission for Accreditation of Hospital Organization. We do have it here, which requires a documented program to show proof. We review the prevention efforts and the causes of incidents. Any incident that happened, even in our radiology, if the patient falls down, from the stretcher or get hurt in the stretcher railing. We record it and we have a witness. So it will serve as a permanent. Then the patient will be seen by a doctor so that the doctor will actually inform what is the level of injury. If not, the patient may go back and say that he had a major injury, but actually it might have been just minor, to cover our staff and all that. Okay, so we have a permanent record of what has been done. Okay, we have this National Institute for Occupational Safety and Health, which is, they did a survey on 3687 hospitals to identify types and frequencies of injury and illness to hospital employees daily, because they are more, they take care of their employees. So the study found that among the exposure types they have, the most common type are strains and sprain. So this might be caused by when they lift patients or they slip and fall in slippery floors or stairs or ladders, because you know that sometimes the mopping is done only when the staff comes in. So this might be an issue too. Okay, hospital occupational. So that is the more national body, but our hospitals also have a health and safety committee. So we pre-place medical examination. So those staff who join the hospital as employees, they will have to do a medical examination to all these new employees so that we know their status. If not, they may say that they might be anemic or something, and then when they come in, and then they may actually blame the x-rays or anything. So we do have their record when they come in already. Lab tests, everything is done. Okay, even drug tests, whether they actually take, all these are done before they join the hospital as an employee. Then we have periodic health maintenance for these people, so that for the staff, as a general examination and assessment of compatibility, if necessitated by extensive illness or job changes. Okay, so this is another thing where, okay, is of concern. Then we have the environment control and surveillance should be provided to detect or avoid or limit harmful occupational exposure. Special attention to be given to hazards, occupational exposure for women of childbearing age, employees exposed to ionizing. We have the monitoring device, nevertheless, which is called the optically stimulated luminescent dosimeter. So the staff actually vary. Employee health and safety records should be maintained in the health unit. This must include examination, injury or illness report, radiation record, and other environmental exposure reports or records. Then in the hospital too, there are other concerns, whether it is kept clean, sterile procedure should be sterile, and all this. So we have this nosocomial infection. This happens to patients. Okay, infection that happens after the patient comes in. They did not have the infection. In fact, during the COVID, there were patients who came in for heart problem and they contacted COVID. So that is a nosocomial infection. Infection occurring during hospitalization is considered the major problem. Okay, cross-infection, the transfer of infection to a hospital patient with a different infection or between different species of animals or plants. So all these things should be well monitored. Of course, we have the hospital team which monitors this. And then we have the patients are potential recipients of infection from sources within hospital and they're susceptible or more liable because sometimes the staff, they have so many patients, radiographers, doctors, nurses, they cannot wash their hand at times after every patient because they're so busy, especially in public hospitals. So they may cause infection. I know nowadays they use gloves, so that's quite easy. They can change the gloves, so that's a better version. They have to be careful when they touch, especially the severely ill, those with low immunity. Okay, so that the patient will resist infection is reduced, especially HIV patient, AIDS patient, because their immunity is already low. So strict adherence to cleanliness and use of protective equipment is important, like masks. I think now we are all familiar with masks after the COVID-19. The overdress where they will wear an apron, which can be thrown disposable, over shoes, all these things, caps and all must be used to prevent infection, especially in the ICU and all the high dependency unit and all that. Okay. Another concern is the safety of workers too. We have to protect ourselves from injury. Whenever you can see the picture, how this man is taking things. It shouldn't be done. They should use a proper ladder and go up and take things, because this may cause strain and sprains. This is why. So proper body mechanics should be taught to the staff. Like as I say, short courses can be had. We can have short courses which is part of their continuous education. As staff are required to have 42 hours of continuous education in Malaysia, so we run this type of courses which will help them. Okay, and they must wear required uniforms. Like the nurses, they wear long pants and blouse. I think it's basically most of the staff are asked to wear similar, and now we have the scrubs and all, so it's convenient for the staff to work. And then walk, don't run. And of course, you can see this lady, how she's carrying the things. And somehow she's quite uncomfortable with her clothes. And at least she has now put it on a trolley and push it. So because these all will cause injury to the spine in later age. And then they have to wash the hands frequently. And if there happen to be an injury or an accident, it should be reported. That is very important, so that there'll be documentation. Okay, as I said, this is proper body mechanics. I still remember this is, we play for the kids. Both the child should be almost the same way to play this seesaw, we call it. Okay, then that's it. You have to bend your knees and lift anything. Okay, that's proper body mechanics, so that when we are old, we will not get pain in our lower back. Okay, another issue, since we are working with high tension cables, okay, even though we do preventive maintenance, and also in the hospital itself, we are using oxygen tank, okay, which is actually enhances combustion. So we have to be careful. If there's a fire, there should be no oxygen tank, should be closed. Okay, any parks, planes, and all should be off, and then fuel should not be there because it will enhance the burning. Okay, and definitely all staff should have courses. Even my students now, when they're students, they have this, how to use, we create a fire outside, and we call our bomba, who is always willing to help, to teach them, because they are good at making the fire and all that. Then they will tell them how to off the fire. Okay, so we have the fire extinguishers, and we have to check whether it expires at a certain date and all. Very important that it doesn't expire and all. So anyway, this is part of the ISO. So when they come, they will check. So we have to make sure Class A is water, class B they have carbon dioxide, dry chem. It depends which section we are putting it. It's the wet lab and all, we need to have special fire extinguishers. We have to move when there's a fire. All patient only very important. Okay, and staff we can announce who are in immediate danger, because patients sometimes they're not mobile. We have to push them out. And we have to activate the alarm. We have to close all the doors and windows, shut off electrical equipment and oxygen, and do not use any elevators. We have to use the staircase. I mean, definitely there's always staircase in any buildings. And then we have to rescue anyone in immediate danger. That's why we have to activate the alarm. And we have to confine the fire and extinguish it. We need some knowledge and skill, especially to off the fire. All staff is part of the training or the continuous professional development. So then we have to, and we want to do this, of course, we have to pull the pin, aim the nozzle, squeeze the handle, sweep base of fire, so we can off it. Because I had the experience of having the high tension cable had fire. So luckily I had the fire extinguisher. I did this and I off the fire. And off the mains first, actually, before you off the fire. Okay, then we need to know our evacuation plans in all the floors. So there'll be a staff actually in charge of all these. He might be a lab technologist, he might be a radiographer, but he's in charge. Okay, there'll be two guys, girls to be in charge. Move horizontally, and all fire doors will automatically close. And then we move vertically. Move ambulatory patient first, then those that need help. And we should not use the floor directly above or below for evacuation because it's dangerous. It may catch fire. Okay, so you see how this fire guys, we call it the Jabatan Keselamatan, Bomba de Keselamatan. So they're very good at rescuing people. Okay, that is more, I was talking the holistic approach of the hospital itself. I'll go more into radiography as it is. There's some safety concerns in the radiography also at times, which is very important because we have to identify our patient correctly. So not only the name, the father's name, and then the my card number, which we have in Malaysia. I'm sure you have it in Indonesia. So we always ask where they stay, where's the pain. Another important concern in radiography is the anatomical markers. Right or left should be placed during the exposure. But now with digital, people put the markers after the exposure. So a few in my hospital where I was in Pusat Perubatan UKM, ini Universiti Kebangsaan Malaysia's hospital, the Ketua Jabatan is particular. He will never let go any images, or if he comes around and sees if people don't put their own markers, he will put warning letters for the radiographers. And then we have to practice universal precaution. Any patient which comes in, say accident cases, which is quite common in Malaysia, we always wear gloves, double gloves. Why? Because we don't know the patient might be a HIV AIDS patient. Okay, so we practice this to take care of ourselves, because as a medical staff, we have to be healthy so that we can take care of the patients. And then verbal errors should not be there. Must tell correctly. Think first before you talk to the patient. Ineffective communication are the common cause of medical errors, risking patient safety. There's another thing called interprofessional collaboration. We have to work as a team with all the hospital staff. Okay, it's a team approach. All right, whether they're doctors, they are nurses, so we have to work as a team. In fact, we start this in the college universities, when they study anatomy, the dentistry students, the medical student, the imaging students all study together certain components of anatomy so that they get to know each other and mix and all, and they share their knowledge about their profession. Okay, another important aspect, as I said, in the radiography department, as I mentioned, those are the common errors we have to take into account. Radiographers pay close attention to infection control measures, especially when the COVID was here, because they are the front line, okay? And not only COVID, when we have all these patients who are infectious, or when we will have patients who are low immunity, like burn cases and all that, okay? So we have to use the suitable isolation requirements as required. Then during the recent pandemic, I think many of us learned this experience. Radiographers were in the front line performing chest and using mobile unit and CT examinations too. So they became very aware about how they can actually prevent infection or minimize it. And they were all in the PPE and all that. Radiographers had to overcome an airborne disease with a high transmission rate. Their anxiety in managing patients at the front line while protecting themselves and other staff from infection was affecting their practice and the well-being. We limited access to PPE, especially in the initial stages, because there were not enough PPE and some of the hospitals in Malaysia were gazetted as the COVID hospital. So if you were there, it was quite experience and challenging to work there. And then the ALARA principle, I'll talk about it later too, as low as reasonably achievable, is also the responsibility of the radiographer in caring for the patient. So let's now start with safety issues or hazards in radiography, because we saw the big picture, now we are tuned to. I think we are very lucky nowadays because I have been in the era of using chemicals for film processing. I have actually worked with the auto processor using chemical but automatic. But I did go to the interior of Malaysia in my first postings. I went to places in Pahang where it's a little bit remote, and I did work with even manual processing, putting on the hanger and showing to the doctor. I had just about a week experience with that. But when I was trained, I was not trained that. I was with auto because I was trained in Kuala Lumpur, which is our capital. Okay, so I would say that now there's no more manual, but there are hospitals using chemicals, not hospitals actually, small clinics like Sabah and Sarawak, I did see. But in West Malaysia and in Klang Valley where I live, no more already. Okay, minimum they would have done computed radiography. So electronics and computers allow the evolution towards the use of filmless radiography. I think this has helped a lot for the hazards of the staff who worked in the dark room, we call it. We call it in Malaysia the juru process, okay, in BM. And they had a hard time because they worked with chemicals inside the room, and at times their lungs are affected, even though there's exhaust and all. So I think we should thank the development of technology that now we did not use chemicals. I'm very glad with that. Okay, so duplication of imaging already performed, another issue I'm talking. So now we are happy, we are into computer radiography where we use plate or digital, where we see the image on the monitor. So there's no hazards. Of course, there might be hazards with other things like we are using a lot of 5G and all that. So that is also has hazards too, but we don't see it or don't breathe it. Okay, duplication of imaging is another concern where patients get repeated on their examination, so additional radiation is given. Sometimes the patients go to a general practitioner, a small x-ray machine, they will do the x-ray, and then when they come, they are referred to the hospital. The image or the radiograph is not of quality. So what happens is being repeated in the bigger hospital. So what they should do, they should send through CDs, or they should save it in the PACS, the picture archiving communication system, so that they need not repeat the image. They can look at the image and the reports, the doctor on the other side in the bigger hospitals. Okay, that's why actually teleradiology should be into place. Okay, that's for radiography. Now we are much better. We have all automated. We need not repeat the image. If you give wrong exposure, you can now post-process it. And if you want to see the chest and the heart, you do one image, you can share. I mean, you can post-process for both. So we are much happier. Okay, and radiation dose is minimized. As for CT, we know that CT gives a very high radiation dose. So there are only two issues in CT. One is radiation protection because of the dose, and one more is contrast medium. Okay. Of course, now the new machines coming with low dose, dual source CT and all, but still the dose is high for computed tomography. So obtaining patient history and conveying instructions prior and after the CT is important, especially, and getting patient's consent is very important. Informed consent was mentioned just now earlier. Okay, it's important because the patient may not even tell you if they're allergic to contrast and all, because if they're allergic, we could have covered them with medication. All right. So, but at times, like emergency trauma patient, we don't give contrast. So we just do the CT. So there's no issue. MRI is another modality which has its own safety concerns, even though we do not have radiation or ionizing radiation. There are concerns which has to be taken into consideration due to the strong magnet. Now we started with 0.5 Tesla, we went to 1.5. Now in most hospitals we are using 3 Tesla. So the magnetic field is very strong. Okay, so it is also important teamwork, education, regular MR safety education, updates, and all has to be done. Okay, so these are issues which has to be taken into consideration. General MR safety risk assessment of the MR facilities has to be done. We have heard about this. The first deadly accident related to MR was reported in 2001 when the 6-year-old Michael Colombini tragically died after being hit by an oxygen tank at a hospital in New York when MR was first introduced. After more than 20 years or 30 years after MR was here, we expect that people have learned to avoid such accidents, but unfortunately, they seem to continue to happen. In 2018, there was a deadly accident in India. In 2019, 2 serious accidents in Sweden, and in October, another 2021. Of course, there are other accidents which happen which are not actually reported. Like I know in our local hospital, nobody died. Luckily, there was no patient inside, but the anesthetic tray was brought in by the nurse and it just went and stuck on the MR equipment. But luckily, there's no patients, so it's safe enough lah, because if there's no death, we are actually quite. So we are now very careful and we educate the nurses, the doctors, the MOs and all when they come in. Do not bring anything which is not MR compatible to the MR room. And of course, the patients wise, we do go thoroughly with them with a checklist. If they have any ferromagnetic substances, we don't allow them to come in. We put them under the scanner and then only the patients come in, of course, without any of their personal belongings like credit card, handphone, and all. Okay, because the system is expensive, we do not want any debts to be recorded. Okay, next we move on to interventional radiology. Is just very upcoming in Malaysia. It relies heavily on the use of ionizing radiation to guide procedures to help patients we see on a daily basis. Okay, so what happens is ALARA has to be taken into account. We have to practice. The fluoro time should be kept as low as possible, but of course it depends on the radiologist or the cardiologist performing the procedure. But as a radiographer, we can collimate the beam as small as possible and pan the table as fast as we can, so that there will be lower radiation dose, and we should stand away from the tube. Okay, and we should put the X-ray tube down and the II up, because that will reduce the dose. Because if the tube is up, the dose to the staff is high. Okay, and of course shielding. I'll be showing you shielding later on under radiation safety. Okay, now the upcoming, we have PET scan, positron imaging tomography, single photon emission tomography. We have hybrid imaging, which are all actually in Malaysia. So the patients in nuclear medicine undergo this diagnostics test with administration of short-lived radionuclides to detect diseases in different parts of the body. Since the amount of radioactivity administered is small, the dose to the staff and patient is minimal. However, the staff should stand a bit further from the patient so that we are there every day. For the patient, it doesn't matter. It's for their medical benefits. It's benefit versus risk. Okay. During the procedure or the scanning, the technologist or the radiographer should not be too close to the patient and maintain an optimal distance from the patient to minimize. For compromised or incontinent patients, care should be taken to avoid contamination of the patient's bed or stretcher. If contaminated, then we should follow the steps of decontamination should be performed. Okay, finally, I will not miss radiotherapy because it is also it's another field in imaging. Radiotherapy comes in because in Malaysia we do have, like in the place I work, UKM, and now too we have the Bachelor in Medical Imaging and Radiotherapy. So they can work in both fields. So radiotherapy is one of the main treatment options for cancer management. Radiotherapy is also one of the safest disciplines in medicine. Even though the patient goes for surgery, goes for chemo, they also go for radiotherapy. Due to the regulations and robust quality assurance program governing the use of ionizing radiation in medicine, yet for some patients, this essential treatment can bring harm, personal tragedy, if precision is not practiced. For radiotherapy, we have to be very precise, we know. And they're the last line of defense in treatment where error detection, because radiation therapies, as we know, they are the last. That means they are the one who actually implement the treatment. The oncologist just recommends the dose, but they actually do it. So they have to be very careful. Okay, daily interaction they have with patient, and they have a unique relationship whereby they can motivate the patient to go through the fractionated dose and all that, and they have to care for the patient. Safety is very important because we have to give the correct dose and we have to shield the areas especially like say you're doing breast cancer treatment and the heart is nearby. So you have to be very precise that the mega voltage dose just goes to the breast and not the heart. So that is why a teamwork is very important. Okay, last but not least, I'm going into the radiation safety for all these procedures. As we know, for female patients in Malaysia, we make sure that we use the 28-day rule for all patients because that's the menstrual cycle. But for examination involving the abdomen, the gonads, and for hysterosalpingography, we use the 10-day rule because we want to ensure the patient is not at all, even fertilization has not happened because only at the 14 days ovulation happen. I mean, plus minus. Okay, so that's why we use the 10-day rule. Monitoring of the staff for radiation exposure, we do it at this quarterly, we check their doses, but every month their OSL or optically stimulated luminescence dosimeter is sent to Agency Nuclear Malaysia for monitoring. Provision and regular testing of radiation protection aprons and gonad shield for all staff and patients. Records indicating the radiation dosimetry stool and staff exposure for the past 12 months are checked. Okay, so we take care of the patient plus the staff. And we have effective strategies. Okay, doubling the distance from the source can reduce the exposure intensity when we go for mobile radiography, minimize time, minimize dose, pre-plan the procedure, use of protective devices is very important. Okay, so how do we limit? As we know, as I mentioned, exposure time, especially fluoroscopy time, minimize distance from the X-ray tube, use shielding. Okay, let's look later. And only patients should be present in the scan room during the exposure. If a doctor needs to be there, but usually he is with the radiographer, holding of patients who cannot remain still, like pediatric, geriatric, the caregiver will be given a lead apron. Okay, so we know for the patient, the risk versus benefit, optimization of radiation dose to produce a diagnostic image, practice ALARA principle, and then measure the radiation dose. Like for CT, we can look at the CTDI. Okay, if for radionuclide, we prevent accidents and clean up spills. Okay, if the solution in any contrast or radiopharmaceutical not labeled, we don't use it. Okay, we read any label 3 times to be sure you have the correct solution. Because if you give a wrong contrast to the patient is at risk and it's expired. So anything should be checked twice, 3 times. And do not mix any solution unless the instructor tells. Avoid contact with skin or eyes. Report all broken equipment and clean up any spills because it may cause fall for others. But of course, with radiopharmaceutical, we have to use the decontamination guidelines. Okay, this is what I was telling. This is personal monitoring, badge, TLD badge. And then we have the lead aprons. Okay, this is what we give to the patients, the surgeons when they do orthopedic surgery. So radiation protection in X-ray lead aprons attenuates scattered radiation by 95%. Okay, and we must care for the lead aprons. We must make sure there's no crack. So in order to overcome cracks, we have to hang it this way. And every 6 months, we have to take images of our apron to make sure there's no cracks. Okay, there are lots of ways to minimize radiation exposure. To practice ALARA, always collimate to the area of interest. The larger the amount of tissue the beam is allowed to irradiate, the more scatter radiation is produced. Avoid holding of patient by staff. Provide protective apron to whoever is holding, especially the caregiver. Always operate equipment from behind the protective barrier or use lead apron. During fluoro, always make sure that you use thyroid shield, lead goggles, and lead apron. During use of mobile X-ray equipment, stand at least 6 feet away from the patient and wear lead apron. During C-arm procedures like in the operation room and all, you stand on the side of the II, which is safest because there's less scatter produced at the entrance surface of the patient. Okay, and when we use mobile equipment and all, ensure that the X-ray tube is immobilized on the stand and all that. Okay, finally, I would like to do a few recommendations. Shield thyroid and gonads, always wear lead apron and use dosimeter to monitor the exposure. CT scan should be justified because CT gives the highest radiation dose. Patient education is important too. Collimate to the region of interest always. Operate from behind the LED protective screens. There should be a universal image bank where patient images can be accessible anywhere from any hospital, that at least in each country, so that when the patient is transferred to another hospital, they can actually collect it from there, just like we are having our Google Drive and we share with our staff and all that. So, in conclusion, or it is the take-home message, is my department, you should ask yourself, safe enough for patient? Okay. Do I know enough about patient safety? If not, you should attend courses. All right. Have I done enough to improve patient safety? Okay. It can be any safety, all right? Patients on the wheelchair, on the how they are transferred, on the stretcher. Do I ALARA principles? And do I use good clinical practice? In other words, how you approach the patients, okay, how you speak to the patient, explain, care, and also on using of universal precautions, okay? These are my references, and thank you very much. I will now unshare the screen.
Thank you so much, Professor Kanaga, for your lightning presentation. It was wonderful.
Thank you.
And now we are going to the question and answer sessions. Well, we have a question here from the pigeonhole. This question from Werima. I'll try to clarify your quest. This question is, I am a radiographer at a veterinary hospital. Which is the better option for us? Using anesthesia, which involves higher cost but ensure better positioning of the animal, or having the veterinarian handle the animal, which saves costs but may expose them to more radiation due to less precise positioning.
Okay. I have actually been to vet hospital. We have the University Putra Malaysia, but not experienced much. But however, what is the better? Anesthesia, but spending more costs on handling. Position of the object is better, saving costs, but they get more radiation. Well, I suppose there are also lead protective devices for animals. Okay. So it should be used. I don't know whether because they use anesthesia. Handling by veterinary, position of the object is better, save cost, but they get more radiation. Okay. All right. Maybe we can use lead protective devices for the animals. That is what I will suggest. And we can collimate the beam further. Okay, so that's my answer.
Yeah, yes,
Um,
agree with you, Professor Kanada.
I
Yeah,
do not have much experience in, we have not done actually on tigers and horses, but I know I got a friend who did this.
yes,
Okay,
okay.
all right.
We're going to the next question.
What's that?
What steps are taken to ensure that patients are adequately informed about the risks and benefits of novel radiological procedures or technologies?
Okay, thank you for the question. This question is basically what we do is we explain the procedure to the patient and get the informed consent if we are giving contrast. But if we are not giving any contrast, we still explain the procedure, and we also explain on the 28-day rule whenever patients are in the reproductive age. Okay, so we do actually explain. At times we have written brochures for the patient. We have in 2 languages, in English and Bahasa Malaysia, so the patients can actually read. We have these brochures in the waiting room, and then our TV in the waiting room also shows the procedures in pictures. Okay, so this will make sure the patients understand what they are going through. But we still explain, even though they have watched in the TV, we still explain. Okay, and we ask them whether they understand or not. Okay, that's my answer for this question.
Yeah, thank you, Prof. And the last from the audience, we have Mr. Aksa. How can interdisciplinary collaboration between technologists, radiologists, and other healthcare professionals contribute to ensuring patient safety in the era of advancing radiological technology?
Okay, thank you. Okay, even though our technology has advanced greatly, but the human touch is still there. Okay, all right. So we have to work like whenever there is a patient, say, undergoing interventional radiology, we always have a discussion before the procedure regarding the patient on with the radiologist, in the radiographer or the technologist, and also at times there be the lab staff who are actually there because they would actually take some specimens and all that. So we discuss the case before the procedure so that all aspects of patient safety is taken into account, so that who is responsible for what. When the radiologist is doing interventional radiology, he is so engrossed with the catheter and where it's going and all that. So the radiographer will be given the responsibility of looking at the patient and talking to the patient. That means whether the lips turn blue ke, dia punya toenails, because they don't wear lipstick or they don't wear nail polish, right, when they come into the room. So we can actually, and we keep on asking the patient how they are you do you have pain, so we are constantly looking at the patient, because the radiologist is unable, his main focus is on the catheterization, because it's not that easy. So we take care of the patient. Even during hysterosalpingography, it is quite a traumatic for women. So we will keep on talking to the patient, asking how she is it painful? And then other staffs are there, like when we do cardiac catheterization, we have the cardiac technicians. So they also will talk to the, look at the patient, monitor the ECG and all that. So without this interdisciplinary collaboration, the doctors cannot perform their duties. So we have to work with them, you know. And suddenly the patient collapses when they're doing interventional and all, especially cardiac angio. We have to do this CPR and all as a team. Okay. So it's a teamwork. All
Yeah,
right.
we have to
Yes.
hand in hand and collaborate together. Yeah,
Yes.
Prof. Kunaga. Okay.
Mm.
Anyway, I want to take a moment to express my sincere gratitude to you. I have read
Yes.
several of your publication on Scopus, and I'm particularly interested in one of your studies. It's about the comparison of radiation dose between EVU and non-contrast helical CTU. Could you please share and discuss this topic with us?
Beg your pardon, I can't really get it. The question.
Uh,
It's my study, right? I
yeah,
understand.
actually, it's about the
On
comparison of radiation dose between EVU and non-contrast helical CT urography. Could you please share?
okay. So okay. This is about the CTU or the CTU, is it? So because I did one on mammography whereby I actually did the less compression for the breast using the tomosynthesis, and it was successful because we can give less compression to the patients, because in Malaysia, even though we have a lot of screening, government subsidized, women are reluctant to come. Okay, so what we did was we actually did less compression and we can get the same image quality lah. That's for memo I did, but this one is must be regarding CTU. I think it's quite some time back. Okay, so maybe if you share a bit of the study, then I'll remember. Is it to do with radiation dose?
Yes, of course.
Can I have? Oh, okay. The title. Then I suppose it was using the TLD, thermoluminescent dosimeter. We actually monitored the patient's dose, and we wanted to compare with the CTDI and all that. I think that was the study which I did. It was quite some time back.
Yeah, what an excellent research. Thank you, Professor Punaga.
Is there any questions?
To our, I think it's enough. To our audience, thank you so much for your active participation and engaging questions, and especially for Professor Kanaga. Thank you so
Thank
much
you.
for your insightful and provoking presentations. And finally, we invite you to accept the certificate from the head of Department of Radiodiagnostic and Radiotherapy Technique. And in this moment, this certificate will give it by Mrs. Darmini from Radiology Program Diploma 3.
Thanks, Mrs. Deka. We express our gratitude to Professor Kanaka Kumari Celia, distinguished faculty member at Asia Metropolitan University, Malaysia, for her presence and participation in the significant event IConTRAS. We also appreciate the insightful presentation you share with us. Hence, we are pleased to present this certificate to acknowledge your contribution to today's session. We trust that this activity proved to be valuable for all attendees.
Thank you very much. I'm very pleased to receive the certificate. Thank you for the invitation.
Halo.
Hi, hi, hi.
Thank you so much, Profesor Kanada.
Halo, Profesor.
Hi.
Thank
I'm
you.
so pleased to meet all of you and thank you for the
Okay.
invitation.
Yeah, Prof.
IConTRAS.
Tanaka. Thank
Okay.
you for your support, time, and sharing your knowledge, Prof. Kanaka.
Thank you. We will meet up soon
Okay.
in further
Hopefully,
conference.
always success and blessing for Prof. Kanaka and Asia Metropolitan University. Thank you very much.
Thank you to IConTRAS for organizing this a very successful event. Thank you. I will leave the session. Thank you all to all the distinguished organizers.
Okay.
Thank you. Bye. See you next
Okay,
time.
bye.
Thank you once
See
again.
you.
You are welcome.
Thank you for the moderator
You.
too. I hope I
Yeah,
didn't miss.
my pleasure. Thank you once again
Yes.
to Professor Kanada and
Yes.
one of you for joining us today. We look forward to seeing you at our next second IConTRAS. Wishing
Sure.
a wonderful day. Good afternoon. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so
Waalaikumsalam.
much.
Warahmatullahi wabarakatuh.
We would like to express our gratitude to Professor Kanaga Kumari Celia from Asia Metropolitan University, Malaysia, for the amazing presentations. And to Mrs. Maria Toljana, Sarjana Sains Terapan Magister Kesehatan, who has guided the presentations of the second material session.
Distinguished guests, we all know that previously there were e-poster and photography competitions. On this occasion, we announced the winners of the e-poster and photography competitions. These are the winners of the e-poster and photography competitions.
The third place in the International Photography Competition is Muhammad Iqbal Yanuar Effendi from RSUD Dr. Sarjito, Yogyakarta. The second place in the International Photography Competition is Maria Magdalena Aminuno from Stikes Guna Bangsa, Yogyakarta. And the first winner of the International Photography Competition is Yanglu Alio Mukni from Health Polytechnic of Ministry of Health, Semarang. The third place in the international poster competitions is Muhammad Rizky Maulana from Semarang Health Polytechnic of Ministry of Health. The second place in the international poster competition is Purwanto from Posaka, Makassar. And the first winner of the international poster competition is Signa Purwitasari from Unisa, Yogyakarta. We give a big appreciation to winner, and we would like to invite Dr. Fatima, Sarjana Sains, Magister Kesehatan, to give the certificate to our winners.
Okay, thank you, Mbak Michelle and Mas MC. Congratulations and success to the all of winners of the photographic competition and the scientific competition. Hopefully, it will inspire and motivate all of us Thank you very much of all. Sukses untuk kita semuanya ya sudah berpartisipasi di kegiatan IConTRAS maju mendunia bersama. Thank you.
Thank you, Dr. Fatima.
On this event, we have door prize. Door prize is given to the first registered of participant is Alia Mustika Putri from Pengcap, Kabupaten Demak. The participants with the highest pretest score given to Nida Dia Ulhak. Top 3 participants with favorite questions. The first favorite question is Nurlaila Yunita. Second favorite question is Septian Eka Saputra. The third favorite question is Werima. For the all winner, please contact to our contact person on the poster. Before we close the event today, to all the participants, please would like to fill in the post-test link provided in the Zoom and YouTube chat room.
Ladies and gentlemen, who have arrived at the end of the event, we would like to thank the participants who have attended and participated in this event. And thank you to Pepe Pari, Director of the Semarang Health Polytechnic of Ministry of Health, and all staff. And thank you to Konica Minolta and Fujifilm for participating and supporting the first IConTRAS 2023 activities this time.
I am Muhammad Hafid Giovanni.
And I'm Michelle Ajung Francita.
As the master of ceremony today, and behalf on the committee, would like to apologize if there were any mistakes in holding the first IConTRAS 2023. Last words. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much. Thank you everyone. Sampai jumpa lagi. See you next year.
Terima kasih. Terima kasih.
Terima kasih Mas Sesio, Ibu Prodi, Mas Haris, dan tim semuanya. Luar biasa. Terima kasih Hima Dema CTRR ya sudah berpartisipasi semuanya. Terima kasih Bapak Ibu Klinikal Instruktur, dosen, staf pendidik kami, dan juga Bapak Ibu peserta partisipan webinar internasional IConTRAS ya. Sukses untuk kita semuanya. See you. Izin live.
Our department was founded in 1984 and has produced graduates who are professionals in the field of radio diagnostic and are spread throughout Indonesia. Our department consists of 3 study programs: the Diploma 3 program in Radiology Semarang, the Diploma 3 program in Radiology Purwokerto, the Applied Undergraduate program in Radiology Imaging Technology. Welcome to Radio Diagnostic and Radiotherapy Technique Department, Semarang Health Polytechnic of Ministry of Health.
Vision: becoming a department that produces intermediate radiographers who have a radiation safety license, mastery of CT scanning and IT, as well as radiographers who are experts in the field of advanced imaging, supported by managerial skills, have noble character, and will be internationally recognized by 2025. Mission: organizing intermediate radiography expert education with mastery of CT scan technology and radiation safety, noble character, and a quality assurance system, and supported by information technology that is measured at the end of each academic year. Organizing advanced quality radiography and imaging specialist education, supported by a quality assurance system at the end of each academic year. Carrying out research and publications in the field of radiography and advanced imaging every year. Organizing community service activities in the health sector every semester. Improving the quality of human resources in order to support the three dharma of higher education. Establishing cooperation with government, private, and community institutions both nationally and internationally.
Radio Diagnostic and Radiotherapy Technique Department has values, namely I help you, integrity, hospitality, loyalty, professional, universal. Our department reputation: excellent accredited study programs, CAN accredited laboratory, the best national PPR training institute in 2019 and 2022. Comforty Test Testing Agency appointed by Bapeten, and also the best non-commercial field PUI or Pusat Unggulan Iptek Developer Major at the Semarang Ministry of Health. The Quality Assurance System in Radiodiagnostic and Radiotherapy Technique Department is carried out with internal quality audits which are held 2 times a year in March and September, and management review meetings which are held 3 times a year in February, June, and October. Our department collaborates with domestic institutions and foreign institutions which include the three dharma of higher education, research, and dedication.